Good evening, everybody in India, and good morning those who are joining from US and Japan, and good evening for those who are joining from the eastern part of the world. It is a proud privilege for me to initiate the proceedings of our annual conference, which we used to hold as a physical meeting in Sir Gangaram Hospital for almost 20 years. The endeavor of our meeting always have been to update the practicing gastroenterologists and hepatologists about the recent advances in field of gastroenterology, hepatology, and recently we have added another armamentarium of therapeutic endoscopy. This time we have tried to have some innovation in the format. We have tried to have the speakers which will tell us the recent advances in the particular field over the last few years, which have either impacted the way we manage the gastrointestinal diseases, or it is likely to change the course of our management in the subsequent years. With that, we have divided the sessions into hepatology, luminal gastroenterology, diagnostic, and therapeutic endoscopy. So today we have a hepatology session, and in which we have 5 major topics which are likely to be covered today. And our format is that for first 20 minutes, our speaker will present the recent advances according to him, which have changed the management of hepatology practice in that particular subspecialty. Subsequently, the moderator of the session will take the clues from the speaker and will try to discuss the questions with the expert panel which we have. We have 5 expert panelists in each session. So by the end of the talk and the presentation, and by the time we summarize the session, we will have a comprehensive review of the recent clinical relevant advances in field of hepatology today. With that, I'll hand over the proceedings to Professor Gauradas Chaudhary, who is incidentally the Director of Hepatology and Gastroenterology at the prestigious Fortis Memorial Hepatology Center at New Delhi. Dr. Chaudhary, please.
Thank you very much, Dr. Anil, and very heartfelt congratulations to you for organizing such a mammoth online conference. And we really look forward to them. The selection of topics have been fantastic. Everything that we would all like to know and hear about. The opening batsman today, I'm sorry, you don't play cricket in the United States, Zubair. I'm so sorry. But the opening batsman today is Zubair Younesi. He's an international celebrity. Anybody who knows anything about hepatology knows his name. It's linked with a whole lot of conditions related to the liver. In fact, one of my PhD students got in touch with him when we were working on quality of life in liver diseases. He was in fact a pioneer. So grateful to you. So he is going to talk about what are the recent advances in NAFLD. But before he starts, it's my duty to just introduce him and say a few words. He's Professor of Medicine, Virginia Commonwealth University, Innova campus. He's Chairman, Department of Medicine, Innova Fairfax Hospital, and Vice President for Research, Innova Health System, Betty and Guy Beatty Center for Integrated Research, Falls Church, Virginia, US. The biodata is long. We have only 20 minutes, but suffice to say, the 3 key points that I picked up from his biodata is that, they have been engaged in hectic amount of research, 90 research projects, and they are more in the realm of translational research, outcome research, and clinical trials. So you know whom we are talking about and what he is likely to talk about. Welcome, Dr. Younesi. After that, we'll have our questions for you. Welcome.
Thank you very much, Professor Chaudhary, and I'd like to thank yourself and also Professor Arora for inviting me. My task would be to give an update on non-alcoholic steatohepatitis, some of the updates, and let me share my slides with you. And I just want to make sure that you're seeing the slides.
Yes, we can see the slides.
Yeah. Okay, great, wonderful. Okay. So I do hear some background conversation, but I'll start with just giving you about 5 minutes about the epidemiology of non-alcoholic steatohepatitis, which is really what you need to do to understand the management of non-alcoholic steatohepatitis as we stand in 2020. And the advances I'll try to actually bring to the conversation or some that are related to the burden of disease, but then also in terms of some of the diagnostic modalities that are non-invasive, and also some of the therapeutic sort of advances that we've had. I'll try to actually incorporate some of the data that was presented about a week ago at the International Liver Congress here. Well, it was a virtual Congress. It was supposed to happen in London, but I'll try to bring you some of that as well. When we're looking at the spectrum of non-alcoholic fatty liver disease, we're talking about not only non-alcoholic steatohepatitis, but also just NAFLD, which is accumulation of fat in the hepatic parenchyma, more than 5% fat, without any evidence of liver cell injury. This is probably the majority of patients with NAFLD will have just fat without any evidence of damage to the liver. Non-alcoholic steatohepatitis is important to distinguish, and currently the distinction is made by through a liver biopsy. Steatohepatitis requires fat, lobular inflammation, as well as just some evidence of liver cell injury, such as ballooning hepatocytes. Now, you have to exclude other causes of fatty liver, as well as other causes of liver disease, including chronic hepatitis B and chronic hepatitis C. In fact, genotype 3 hepatitis C does cause a fatty liver that's related to the virus. The entire spectrum of NAFLD is associated with conditions of metabolic syndrome, type 2 diabetes being the most important one, as well as visceral obesity. The global prevalence of NAFLD is about 25%. This is from a meta-analysis we published a few years ago. The highest prevalence is in the Middle East, as well as South America. In Asia, the prevalence was reported about 27%, but more recent data suggests about 29%. And as you can see, the prevalence in Australia is somewhat around 27, 28% as well. In type 2 diabetics who are at highest risk, the prevalence is about 55% of the general population, or the population with type 2 diabetes would have NAFLD, again, very high prevalence in Middle East and South America, as well as Europe. The lowest prevalence rates are being reported from Africa. This may be underreporting, but in the context of NAFLD, the lower rates are being reported from the continent of Africa. Probably not South Africa, and probably not North Africa, because North Africa is similar to Middle East, and in South Africa, the prevalence rates are probably very high as well. In children, of course, is the major concern we have because of the tsunami of fatty liver disease that's going to come down the pike in the next few decades. The prevalence is about 7.5%. Again, the highest prevalence in children is being reported from South America. The subtype that's progressive, the non-alcoholic steatohepatitis, the prevalence in general population has to be estimated because you can't biopsy general population, and that prevalence is somewhere between 1.5 to 6.5%. In type 2 diabetic, the prevalence of NASH is about 37%. So a third of diabetics will have histologic evidence of steatohepatitis, and probably about 15% or 20% will have actually significant fibrosis F3 or F4. When you're looking at the entire spectrum of non-alcoholic fatty liver disease, the most common cause of death is actually cardiovascular death. It's not liver. The NASH subtype can progress to cirrhosis and would be at risk of complications, such as decompensated cirrhosis. Two peculiarities about this disease. One is that most patients with HCC that have underlying NASH, they would have cirrhosis, but there are patients without cirrhosis in NASH that can also have HCC. The incidence of HCC in the non-cirrhotics is much lower, and it's below the threshold of screening to be cost-effective in this population. So screening still needs to happen in those with advanced fibrosis with NASH for HCC, but at least be aware of the fact that some patients with NAFLD without cirrhosis can also have HCC. The second peculiarity is that this disease may not be linear in terms of progression. So there are actually periods of progression and then periods of regression or stability. This, of course, leads to very high placebo rate, because placebo patients can actually, in clinical trial, can also get improvement. 10 to 20% of patients are in that category. These are some of the evidence from the United States suggesting that NAFLD is NASH or associated with very high rate of mortality. The more components of metabolic syndrome you have, the higher the mortality. Currently, NASH is the second indication for liver transplantation in the United States. In fact, among women and among those who are over 55, it's the #1 indication for liver transplantation. It's among the top 3 causes of cancer, liver cancer in the United States. The prognosis of these patients tend to be actually worse because they come in with larger tumors. And when you look at our data from ENHANCE, it is becoming the prominent liver disease, the most common liver disease, and it's going up. And if you look at the mortality data that we have from the National Center for Health Statistics, it's actually a very common cause of death and death certificates, and it's going up. Like on the other hand, hepatitis C in the United States is coming down. And when you look at modeling, again, there's estimated that in the next 10, 20 years, we will have a massive increase in the number of complications related to NASH and NAFLD. Globally, this is from GBD data that we published recently. In most regions of the world, when you look at liver cancer or cirrhosis mortality, you'll see that they are in red boxes when it's related to NAFLD, meaning that they are increasing as the cause of mortality related to mortality secondary to NAFLD. When you look at in comparison in the box that has to do with hepatitis B, in some regions of the world, you see that they're green, suggesting that the burden of disease related to hepatitis B may be decreasing, while the burden of disease related to NAFLD is increasing. It is also important to remember that NAFLD is a part of a systemic disease that is not only associated with cardiovascular disease, but also extrahepatic malignancies, including gastric cancer, colon cancer, pancreatic cancer, and even lung cancer. Quality of life is also impaired in patients with non-alcoholic fatty liver disease. The bottom is from STELLAR 3 and 4 data, baseline data that we presented. Again, not only quality of life is actually impaired, but also there is actually further impairment of quality of life when you actually have more advanced fibrosis. The top graph shows you from a registry, a global registry that Dr. Duseja is an active member of that, showing again that NAFLD patients have impairment of quality of life. Economically, in the United States, this is Markov models that we have published, that the cost, the lifetime direct cost of advanced NASH in the United States is about $100 billion. So not only it is associated with clinical outcomes, quality of life outcome, but also economic outcome. In terms of pathogenesis, this disease actually is not a simple disease. It has multiple different pathways. And it could be related to of course, insulin-resistant and visceral adipose tissue, secreting the inflammatory adipokines and cytokines. In some patients, it could be related to dysbiosis, and others it may be related to oxidative stress. In fact, I believe that in a single patient, you can have multiple pathways activated that leads to the activation of the stellate cells, and of course, development of fibrosis and cirrhosis. The gold standard for diagnosing steatohepatitis is liver biopsy, of course, but liver biopsy is invasive and it's not easily acceptable to a lot of patients. So a number of non-invasive tests are being developed, and I categorize them in terms of those that detect steatosis, those that detect steatohepatitis, and those that are fibrosis. Finding fat on the liver is easy by ultrasound and, of course, MRI, PDFF, and FibroScan, which is a transient elastography, can also give you this, but ultrasound is probably the easiest one. The non-invasive tests for steatohepatitis are not currently well accepted or validated. So most of the biomarkers, non-invasive biomarkers, are focused on fibrosis. The ones that are easy to calculate are listed here. This is from just clinical data that you can have from patients in their clinical chart. FIB-4, APRI, and NAFLD fibrosis score. I personally use FIB-4 more commonly in the United States. If a patient has a FIB-4 less than 1.3, this is the most updated data, it suggests that this patient probably does not have advanced fibrosis. And in India, I hear that cutoff is about 1. So it may be different cutoffs in different parts of the world. One of the non-invasive serum tests that is available and approved in Europe, but not in the United States, and would be helpful, it's the ELF test, or enhanced liver fibrosis test. Again, it's the components of that is procollagen 3 and NP, as well as hyaluronic acid and temp. When you look at a cutoff of about 10, this test can actually accurately separate patients with advanced fibrosis. So this test, when it becomes available, would be a good non-invasive test to be used. Imaging modalities, transient elastography, of course, is the one that's point of care. Will give you a liver stiffness. If you have a liver stiffness of more than 8, there is significant fibrosis. If you have a liver stiffness less than 6, in the United States at least, that suggests that that there is probably a very, very low likelihood of fibrosis. It also will give you CAP, which is a quantification of hepatic fat. Now, in addition to this, RFE and shear wave elastography are 2 other modalities that give you pretty much the same type of data. MR elastography, which is based on MRI, will give you liver stiffness and a MRE of 3.63 or higher suggests advanced fibrosis. It will also give you PDFF, which is quantification of triglyceride or hepatic fat. I would submit to you that probably MRE is the most accurate test, but it's also more expensive and less available. FibroScan, which has both transient elastography with CAP and AST, has been combined to develop this test called FAST test, and it was published in Lancet by Phil Newsom recently. And as you can see, if you're more than 0.67 in FAST test, that suggests actually that there's significant fibrosis as well as significant activity in terms of a NASH score of 4 or higher. This study was presented at the last International Liver Congress a couple of weeks ago, looking at the MRE. Now, one of the biggest advantages of these non-invasive tests is that it has very good negative predictive value, meaning that they can easily tell you if the patient does not have advanced fibrosis. The challenge, of course, is positive predictive value. We want to know if patients have actually more advanced fibrosis. So this publication, which was from UCSD, with also a validation cohort from Japan, looked at the positive predictive value of combination tests. And when you look at MRE and FIB4 together, you get basically a very high area under the curve and actually a positive predictive value that's between 93% in the developed part of this algorithm and 91% in the validation cohort, suggesting that when you combine FIB4 followed by an MRE, you may have a very good test for positive predictive value. We use different algorithms. This is one of the algorithms that can be used. So in the primary care setting where or general gastroenterology sort of setting where you have a patient with component of metabolic syndrome, if the FIB4, at least in the United States, is 1.3, maybe in India that would be greater than 1, you would actually consider a second line test, such as a transient elastography. And for us, if transient elastography is more than 8, the patient is actually at risk for fibrosis. So if less than 6, those patients are really not at risk, and we send them back to the primary care for management of their cardiometabolic risks. If you have a FibroScan of over 12, then that actually suggests very advanced fibrosis until proven otherwise. And of course, that's how we use these tests to manage patients in clinical practice. Treatment of NAFLD, of course, as a public health intervention, which is a societal policy sort of issue, but there are a number of other targets that we need to look at. The most important aspect of this is that the patients that require liver-specific treatment are those that have NASH and those that have NASH with advanced fibrosis. And in that context, lifestyle modification with weight loss, of course, is the first thing to do. And more than 10% of weight loss is actually excellent in terms of achieving histologic improvement of even fibrosis, but it is hard to achieve. Less than 10% of patients actually achieve that more than 10% weight loss. When you combine diet with some moderate physical activity, that means 30 to 40 minutes of exercise 3 to 4 times a week, then you will actually improve not only weight, but also potentially intrahepatic fat. This was a combination of Mediterranean diet with moderate physical activity that led to improvement of visceral adipose tissue as well as intrahepatic fat. Drugs that are available in the United States, they're listed in the list, the ones that has been used. I know that most of these drugs actually are not recommended by AASLD. Saroglitazole, which is basically a drug available in India, and there is a number of good studies suggesting that that'll be a good drug to use. In the United States, of course, this drug is not widely used for treatment of NASH. Pivens was the first trial that suggests that pioglitazone may have some role, and then this study from Kenkuzi suggested pioglitazone at 30 to 45 milligram per day for 18 months was associated with improvement of not only resolution of NASH, but also improvement of other histologic parameters, including fibrosis. Vitamin E is another drug that we'll use in the Pivens from the National Institute of Health here. Again, at 800 national units per day, it was suggested that vitamin E can actually be effective in non-diabetic patients, non-cirrhotic patients with NASH. And finally, vitamin E in advanced patient has been used in a retrospective case control study. We still have some way to go. New drugs. This is the thyroid beta agonist phase 2 clinical trial. And as you know, this is a drug that can address a number of metabolic conditions. And in that context, there is improvement of not only ALT, but also hepatic fat. This drug was also presented at the Liver Congress with additional data. GLP-1s, semaglutide is the new kid on the block and actually improves not only weight, but also liver enzyme. Phase 2 clinical trial should be presented soon. And when you look at selonsertib, this was an ASK1 inhibitor from Gilead, and although initial data suggested some improvement of fibrosis, phase 3 data with Stellar 3 and 4 wasn't actually very helpful. And again, PPAR, dual PPAR elafibranor initially suggested improvement in resolution of NASH in large number of patients, but unfortunately, Resolve It, which was phase 3 clinical trial, did not show this. This was a press release a couple of months ago. Sinequirvarok has been shown to probably improve fibrosis, and this drug is going to be probably released next year in terms of its phase 3 Aurora study data. Finally, obeticholic acid, the initial Flint study suggested improvement in phase 2, and then of course I presented the Regenerate data. And in this context, obeticholic acid at 25 milligram per day was better than a placebo in terms of improvement of fibrosis by 1 stage or higher without worsening of NASH. And in fact, there is more data that when you expand the population of patients to include now stage 1 patients with some risks, you all not only see improvement of fibrosis, but also resolution of NASH. Liver enzymes actually improve. As you can see here, this is actually data presented at the EASL 2020 at the Liver Congress just last week. And again, when you look at fast testing, there is actually improvement of fast testing in these patients. And when you look at improvement of a number of other non-invasive tests, what is AST, ALT, APRI, FIB4, transient elastography, okay, even at 24 months was actually significant improvement. So the first data that I showed you, that was 18-month interim analysis. Now there's data from non-invasive tests up to 24 months showing that actually some of the improvement remains. Side effects, of course, are related to they're related to some pruritus and LDL increases. Pruritus is actually managed in general very easily. Quality of life is not terribly impacted by pruritus. So I suspect that most of these patients will just do fine. And in terms of LDL increase, very easily managed with statins. And in fact, patients who are started on statins at the end of treatment will not only get back to baseline, but some actually improve. One last trial that I would show you. This is basically a combination of different drugs by Gilead Sciences. This is called Atlas clinical trial. And as you can see, there are a number of different arms for this study, including some of the FXR, selonsertib, Silo, which is an ACC inhibitor, and as monotherapy, but also as combination therapy. The bottom line is that when you look at this and you look at stage of improvement, a couple of combination, specifically those that combine Silo and FXR, could have actually a potential improvement of both fibrosis and potentially other parameters or histologic features that was shown in that presentation. Of course, this has to go to phase 3 and show that whether these drugs truly in combination can improve things. And my own personal view is that since NASH has multiple pathways, we need to address multiple pathways to get to treatment of NASH. The second important issue in terms of treatment of NASH is that NASH is not going to be treated like hepatitis C for 3 months of treatment. It's going to be like treatment of diabetes, meaning that there's going to be an induction phase with multiple combination of drugs, with a maintenance phase that could potentially be for longer use. So in summary, what I've shown you in terms of NASH is that it is the progressive form of NAFLD, and its complication is growing everywhere in the world, including India, Middle East, and other part of the world. And it's a part of multisystemic disease. There is a increasing evidence that extrahepatic malignancy is going to be an important part of this disease. At the moment, stage of fibrosis is the most important predictor of outcome, and this is why patients with stage 2 or higher are part of the clinical trial selection. And in fact, the non-invasive tests are focused on actually finding fibrosis, patients with advanced fibrosis. And these NITs are being developed and validated. In management of NASH, currently, we have to treat all patients with NAFLD in terms of their cardiovascular risks. We currently have a team of integrated specialists and primary care physicians that will deliver not only telemedicine, diabetes expertise, nutrition, and exercise, but also for some patients with NASH, there may be not only lifestyle modification, but also new drugs that are coming down the pike. So I'm going to stop here. And again, thank you very much for the invitation and for your attention.
Thank you, Professor Yunusi. I think that was, as usual, a wonderful presentation. Dr. Gordas Chaudhary is supposed to moderate this, but then I learned that he has had some issues with his power failure. So maybe I'll start the ball rolling, and then I think he can chip in there. So I think before we take on the questions from the panelists and from the audience, I think you did mention about the non-invasive assessment, which is so important in these patients, and to categorize them into whether they are NAFL or NASH or cirrhotics. So, and you did mention about the FAST score. Just to add, I think we recently looked at the validity of this FAST score in Indian patients, because in the data which was published in Lancet Gastrohepatology, they had some data from Asia, but the Indian cohort was missing. So we thought, let's look at this and see how good or bad this FAST score is for Indian patients with fatty liver. And what we found was that we probably have to use different cutoffs to reach the same sensitivity and specificity. And what we again found was that it all depends on the severity of the liver disease of fatty liver in that particular cohort where you are applying this FAST score. So for example, we had only around 12-15% of the patients who had the NASH with NAS more than 4 and F2 or more. So that cohort was only around 10-15% with us. So that is why I think the figures changed in there. So I think any thoughts on this? I think, do you have data from other centers where again it is dependent on the prevalence of the severity of disease, and that would determine that which score and what should be the cutoff you need to use there? Maybe your thoughts on this?
Yeah, I think Professor Desage is absolutely correct in saying that a lot of these tests, when it's developed, it has to be validated in different populations. And it may have to do with two things. One, it may have to do with the profile of patients that you have, both in terms of prevalence, but also the prevalence of visceral obesity and other things that actually could impact the transvelostography potentially, and other areas. The second thing that's really important is that we assume that the pathogenesis of NASH is the same across the globe. I do actually submit to you that insulin resistance actually plays a very important role in the pathogenesis of NASH. However, what you see in India may not be exactly the same what you see in the United States or in Europe. So when you have these tests like FAST test or ELF test or any of these other tests, I think it's absolutely important to validate in different population. And as I mentioned, and I learned this from you and from your colleagues about the FIB4 test, that FIB4 test cutoff is actually for India is 1, when it's 1.3 in the United States. So it is absolutely critical that we do this, and the threshold could be different, as you just showed with your excellent contribution.
Just one more small point, and then I'll open it for discussion about, we are fortunate enough in this country that at least we have one molecule which is approved by the licensing authority, which is the Drug Controller General of India, and saroglitazar. And this is based on the histopathological study, which we finished last year and which was presented in APASL this year, of around 102 patients, where it did show, in comparison to the placebo, I think the NAS score reduction of 2 or more points was seen in more than double the patients, around 55% versus 23% in the placebo. And then we also have a large real life data of maybe around 5 to 10,000 patients where people have shown a reduction in CAP score, LSM, and biochemical improvement with this molecule. And it's considered to be a very safe molecule. So we are, kind of privileged to have at least one molecule, but for you, it's only vitamin E what I see today. And other than that, I think you don't have any other molecule. So how do you would like to treat a patient with, say, fibrotic NASH? I mean, other than vitamin E, any other drugs you could use?
So I think in the United States, of course, we are pretty limited in terms of what you can use. We all send our patients to experts that at least I have in my team for diet and exercise, and as you know, it's hard to do. We use vitamin E for patients who are non-diabetic with biopsy-proven NASH. I do not use the vitamin E for patients with advanced fibrosis, especially those with cirrhosis or advanced cirrhosis. Pioglitazone is something that we do use for patients with at least I use pioglitazone for those who are diabetic with NASH, at least make sure. And then, although liraglutide or semaglutide are not actually approved and not fully recommended for treatment of NASH, but most of these patients have type 2 diabetes and obesity, and these are indications for these GLP-1 agonists in the United States. So I do recommend that some of our patients who actually can have that in the context of their regimen to have a GLP-1 in the context. But you're right, I think we need to have more drugs soon.
Sure. So I think Professor Chaudhary is back, so maybe he can take over and carry on the discussion here. So you're mute, sir. You need to unmute yourself. Yeah.
Zubair, I just missed the last 5 minutes of your talk, but I must tell you, this is one of the most splendid coverage of recent advances in 20 minutes that I have ever heard.
I appreciate it. Thank you.
Absolutely perfect. You touched on all the 5 aspects and just to the point and showing the most relevant recent slides. Excellent. We have a very distinguished panel of Indian hepatologists. You have just met Ajay Duseja. We have Professor S.P. Singh from the eastern part of the country, another doyen in fatty liver disease. We have Dr. Manav Vadhavan from Delhi, and we have Dr. Anuradha from Sri Lanka. Yes. And I think I missed out one other person, Akash Shukla from Mumbai. Akash, are you there? Yeah, you're there. So I think that it would be fair for me to actually invite Dr. Anuradha first, because he's in a way a guest and a host. I mean, we are in the same region. And he comes from the North Colombo University Hospital. I actually did a workshop there way back in the 90s.
Thank you.
Your De Silva was there, and I think he was your dean. And
he's still there. Yes.
Oh, wonderful. Dr. Anuradha, your comments first to Dr. Unisi.
Yeah,
or
yes,
whatever.
thank you, Dr. Unisi, for wonderful presentation, which was up to date. I just have one question for you. In fact, two questions. One is, do you treat them if they refuse a biopsy, if the liver stiffness is more than 8, you still treat them without a biopsy? Or the yeah. And the second question is, do you regularly start them on a statin? Those are the two questions from me for you, sir.
Well, thank you very much. So, well, I know most of my colleagues and some of my very good friends. Professor Duseja has been a colleague and a friend for many years. I'm privileged to be among all of you. Now, in terms of treating patients, this is really a changing scene in the United States. So if you look at our guidance document, the AACLD guidance document that I was a part of with Naga Chalasani and others, it required the liver biopsy for any treatment. So, for example, vitamin E and pioglitazone has to be used in the context of a liver biopsy. But things have changed. I mean, if I have someone that has significant fibrosis and refuses a liver biopsy, am I not going to have that patient be treated for whatever we have? I do want to repeat, because there is false negative tests, as you can say, even with transient elastography, that I'm not committing someone for a very long-term and potentially lifetime treatment. And then some of these drugs do have side effects. Pioglitazone have potential adverse events. So for those that actually have persistently high fibrosis sort of scores, I do suggest, of course, and we've exhausted everything else in terms of treatment, of lifestyle modification. I do suggest on a case-by-case basis. But at the moment, the guidance document requires a liver biopsy.
Dr. Unisi, can I just interrupt here? You know, two questions have come up from the audience, which I thought were relevant to what you're discussing right now. One of them is, when you advise lifestyle, which diet is appropriate in NASH? This is a question. Is it hypocaloric versus balanced ketogenic versus Mediterranean, or what's the fancy diet that you recommend?
I think this is, again, a very controversial issue. And again, depending on the part of the world, you probably will have different data. And again, as AJ suggested, that a lot of these diets can also be implemented in different part of the world, and maybe different diets. For the North American and potentially European countries, and as I showed that piece of the information, it's really the Mediterranean diet plus moderate physical activity. Now, of course, whatever diet, and this is really my own view, whatever diet that can actually lead to weight loss, sustainable weight loss, in my view, is going to be beneficial. The Mediterranean diet is not a diet; it's a way of living. I mean, of eating certain things and not certain other things. So it's not a diet that one can implement. But I think whatever leads to weight loss and reduction of visceral adipose tissue, in my view, would be beneficial. Some diets may actually create an environment that would be more inflammatory and damaging. So I would stay away from those. Maybe some of the very harsh ketogenic diets would be in that category, which I personally feel uncomfortable with. But in general, whatever other diet that can lead to weight loss would be important.
Thank you so much. You know, we have three very eminent people on the panel. I must give them a chance to ask one question each. Professor Singh, can we start with you, please? If you can unmute yourself. Akash, get ready. And Manav, three of you, your comments.
Yeah, Zubair, I don't think there are any questions to be asked, but the fact remains that the population of NAFLD which you deal with and we deal with are completely different. Our scoring systems, we haven't yet settled with our scoring system. We need to settle with a scoring system of FIB4, NF, etc. We did a small study. Those cutoffs which you talk of, they don't work at all in our population. So we need to have our own scoring system if we have to go by that. But the fact remains that, as told by you, diet doesn't matter. I don't also believe in that. Ultimately, what matters is that the patient takes whatever diet, loses enough weight is physically active, and that gives the best result.
Thank you. Dr. Shukla, your comments? Actually, Dr. Anil is on the phone reminding me that we have to wind up. So that's the reason I'm just hard pressed to get a comment from each of you.
Thank you, sir. I think continuing in the same vein, talking about the heterogeneity, I think we have experienced it here in Mumbai itself in our own 2 studies. When we looked at the non-invasive markers in the urban elite, higher socioeconomic class, along with Professor Samir Shah, we found that FIF4 did the best, and we got a cutoff value of 1, which we published in J. et al. And when we looked at the same markers in patients living in urban slum dwelling areas of Dharavi from Sion Hospital, we got the APRI performing much better with the AUROC of 0.91. So, which we published in BMC Gastroenterology. So, I think even in the same city, amongst the classes also different biomarkers are performing differently, which we still don't know of. So, I think we agree that we need to individualize these things as well, looking at the populations.
Thank you very much. Manav, your comment.
Thank you, Dr. Yunussi, for such a brilliant presentation. For the want of time, I'm not making any comments. Dr. Anil Arora will be happy. Thank you for a brilliant exposition.
Thank you very much. And once again, let me compliment you, Dr. Yunussi. It was a pleasure. I had listened to you a long time back in London when you had presented your data on the quality of life. And in fact, one of my PhD students who was working on nutrition and liver cirrhosis got the, asked you for permission to validate it in India. I think you were very gracious to give the permission long time back. It was really a pleasure listening to you. Anil, over to you. We haven't crossed the time. We started 5 minutes late and we have actually finished on time.
Thank you so much. It was a pleasure, Dr. Chaudhary, for doing an excellent job of keeping up to the time. And I think Dr. Yunussi is becoming the household figure in India now, with excellent talks recently on obitocolic acid, non-alcoholic fatty liver disease. You are a household name, sir. And as Dr. Chaudhary pointed out very clearly, this is an excellent overview of the topic in limited time. With that, I thank all the speaker, moderator, and all the expert panel members. And we switch on to the second presentation of today. That is the recent advances in hepatocellular carcinoma. To talk about that, thank you so much.
Thank you. Bye-bye.
Thank you. Thank you.
To talk of recent advances in hepatocellular carcinoma, we have none other than Professor Robert Gish, who is one of the leading figures in trying to elucidate the algorithmic management of hepatocellular carcinoma all over the world, including the newer therapeutic drugs which are coming into being. And with that, I'll hand over the proceedings to Professor Vivek Saraswat to start the session. Professor Vivek, please.
Yeah, good evening, everyone, and a warm welcome to all the panelists on this session and the speaker. In fact, I think we are starting off right on time, and it'll be looking forward to this session on recent advances in hepatocellular carcinoma. We have, I think, about 35 minutes or so for this session, beginning with the presentation by Professor Robert Gish. And without much ado, I'll introduce him. Not that he needs much introduction. I think he's been heard regularly on these sessions and he's been participating in the Gangaram sessions on hepatocellular carcinoma on earlier occasions. Professor Robert Gish is the clinical professor in Adjunct Department of Medicine, University of Nevada at Las Vegas. He is also the vice president of the foundation of in Palm Desert in California, in the Fat Foundation in Palm Desert, California, and the medical director of the Asia Pacific Health Foundation in San Diego in California. He has a long-standing interest and is a well-known figure in hepatocellular carcinoma worldwide. And with that, I'll request Professor Gish to make his presentation. And we'll, at the end of the talk, we will have questions and discussions with the panelists. So without further ado, I invite Professor Gish to please proceed.
Thank you, Professor Vivek and Dr. Neil Arora for having me for this presentation. Let me get my slides launched here correctly, if this is good. And I'm going to go next to screen share, presentation mode. One more second, warm up. And let's make sure we have the right slides. Does that look good to everybody?
Yes, we are fine, looking fine.
Excellent. Good morning, good evening. I also am the medical director of the Hepatitis B Foundation. I'm on the faculty of Loma Linda University now, and also University of California, San Diego. So I'm working in a variety of places, and my clinical practice spans California and Nevada. I also work very intensely in Vietnam with colleagues there and a number of other countries, so I'm quite honored. My disclosures are on my website. I'd like you to point you to my website for lots of other information. Downloadable material. There's a newsletter you can subscribe to. Lots of great resources. So let's get to what we're going to cover today. I was asked by the moderators to look back just over the last 2 years and what are the hot topics in hepatocellular carcinoma. So we're going to be moving through a number of modules, a number of really hot different areas, understanding that most of the audience here is probably or are probably already experts in managing HCC. So what do we need to think about today? How are we going to change our practice? And it's always good to start out with an epidemiology slide and the fact that we've got incidence data, we have prevalence data because patients are living much longer now with their liver cancer. And then we have mortality data, and mortality data is going to change in 2 directions. If the incidence is rising, and management is suboptimal, mortality will be increasing proportionally. If we have new and better therapies, including curative therapies, mortality rates will be falling. So we need to look at that dynamic. The 5-year survival rate overall is still dismal. We have a long way to go. And with a target of overall survival should be in the 50% range if we had all the tools available today to all of our patients. So I'm going to go to the US just for a moment, but this really reflects what's going on worldwide. I'd like to highlight that NASH is emerging as the leading cause of hepatocellular carcinoma in different age groups, specifically in different populations. Hepatitis C, we have a cure. Hepatitis B, we can suppress the virus, although there is no cure. Alcohol abuse, alcohol-induced liver disease is a problem, but these patients often have morbidity and mortality events that may not allow them to survive until they get liver cancer. Idiopathic is actually quite rare. We can explain most liver cancers now on a pathophysiologic or molecular basis. So let's go to etiology just for a second. As you know, these patients move through inflammation to cirrhosis in most, but not all, to dysplastic nodules, early and progressed hepatocellular carcinoma. But I would like you to look at the box at the lower right-hand corner of this slide and think about what we're doing today, what we're going to be doing in the near term, which is looking at the tissue characteristics of the hepatocellular carcinoma. So a theme today is to be thinking in the near term about biopsying more and more patients, not to prove they have liver cancer, because liver cancer is diagnosed by imaging, and we'll get to LIRADs in a few moments. But now getting tissue to decide what therapies are best for individual patients, especially since 10% or so of our HCCs are mixed with cholangiocarcinoma, and an FGF2 receptor could indicate an indication for some of the newer therapies we have, just as a single point. We also have other issues such as chromosomal instability, inflammatory, CTNNB1 mutations. All these are part of assessing that histopathology, and I'll be getting into this in a little bit more detail. But before we do that, I want to talk about surveillance. Surveillance of HCC is standard of care in patients who are cirrhotic. It's also emerging as standard of care in patients who are F3 hepatitis C who are viremic, and what to do after SVR we'll talk about today, and also F3 patients with NASH. But that's a huge population, and we need to figure out how to subcategorize those patients. And I'll propose to you today that the GALAD score may be useful in those F3 patients on who should go through sequential surveillance and who can be followed up with just laboratory testing. The GALAD score, of course, is made up of gender, age, AFP, AFP-L3, and DCP. In India, I think that is termed PIVKA2, but I'll use DCP predominantly here. This is a nice algorithmic approach on how to do that. Please make sure your ultrasound is high quality. We've identified that quality is a major issue in early detection of hepatocellular carcinoma. And if you have a low quality ultrasound, your radiologist should be so stating, and then you need to move to CT or MR. MR is preferred for me, but I understand that CT scans can be much less expensive in different parts of the world, including India. So may be useful as part of the surveillance algorithm. But again, you need to have a good quality ultrasound, typically about 20 minutes. All right, let's look at a little bit more detail about the GALAD score. Look in the methods section on the right side. 60 established or novel biomarkers were assessed in this study by Suyatek de Lang, presented at EASL just a week ago. 308 HCC cases, including 125 that would be considered early detection. These were BCLC 0 or A with matched controls. They performed univariate and multivariate analysis and looked at the performance of the GALAD score in panels in relationship to the GALAD score. So they really looked at GALAD scores, at least the gold or silver standard, if not yet the platinum standard. In these results, we had criteria that were for the sensitivity and specificity of these different analyses. Excuse me. In over 100,000 analyzed combinations, AFP and DCP were the strongest features or predictors or allowing early detection. Other were such as IGF, COMP, or MM3 as well. Biomarker performance was influenced by disease etiology. So now we're gonna have to be thinking about biomarkers and the underlying disease. So AFP alone had robust performance, but I want to introduce on another slide what's the correct cutoff for AFP. And it's probably 5.5. We have a new healthy for ALT and AST of 25 for women, 35 for men. Alkaline phosphatase is probably 85. GGT is 35. So think of AFP at 5.5. DCP had some limited performance in alcohol-induced steatohepatitis. We have some new biomarkers that look better in NASH and ASH. And AFP-L3 had limited performance in NASH, meaning AFP and DCP may be the most useful tools in our F3 NASH patients as well as F4. Look at the GALAD score. AUC 95% for all HCCs. That's not so useful because you already know they have liver cancer, but for early detection, an AUC of 90%. So I'm going to recommend, following this presentation today, that the GALAD score be part of your surveillance strategy in all cirrhotics and in F3 NASH and F3 Hep C patients who do not have SVR. Well, we can go back to some simple scores. This is data from 2019 from one of our Asian groups. Very simple to score patients at an age of 40. So 40 where you really are going to start thinking about doing surveillance. Cirrhosis, of course, is key. Men having 2 to 3 times the risk of HCC as women. And of course, starting surveillance earlier in your diabetic patients. So if you have a gray zone patients, that's a late F3, they're age 35, but they're diabetic, I'll be starting surveillance in those individuals. Let's now move back to how you diagnose liver cancer. Liver cancer is diagnosed not by alpha-fetoprotein or biomarkers. It's not diagnosed by biopsy, except in special settings. You're going to be performing LIRADs on all patients with cirrhosis with liver observations. Instead of calling it a tumor or a mass, in the LIRADS lexicon, we call them observations. And of course, we have special scoring systems I'm not going to go into in great detail. And I'm biased towards magnetic resonance imaging because in head-to-head studies, magnetic resonance has a higher sensitivity of probably at least 10 or 15% for early detection of HCC. Now we're going to move to treatment because that's really a super hot topic now. I'm not going to go through every part of this beautiful graph. I've updated it a little bit from the 2018 publication, but we have level of evidence along the left side and weak or strong or negative recommendation along the bottom. The highlight I'd like to have you eyes move to the upper right-hand corner because now we have a first-line therapy of atezolizumab, a PD-L1 inhibitor, and bevacizumab, a VEGF inhibitor. First-line therapy And I'll go into the data on that shortly, with a median survival in the treatment arm that still hasn't reached a median level, and it's probably over 30 months. We have great first-line therapy of oral therapy as well, and lenvatinib is probably one of the hottest medications. Little less side effects than sorafenib and much better progression-free survival. I really want to emphasize to please treat aggressively the underlying disease in all your patients with liver cancer. Treat their hepatitis C immediately to cure. Suppress all hepatitis B patient with oral nukes. Aggressively manage NASH. Stop all alcohol consumption. Remove iron. We have a variety of other combinations here. I'd refer you to this slide at the end of this presentation to think about what strength and what level of evidence and what level of recommendations. So there's been a lot of clinical trials here. We've had some great recent advances. I'm going to go into some of these different here that are in blue and green, but on the other side of this slide is what has failed. Second column down, we don't have good evidence on TACE. And if we're going to be combining TACE with targeted therapies such as sorafenib. There is a tactics trial coming out of Taiwan that may be useful and show us where this may have a role, but we really haven't refined how to combine transarterial therapy with targeted therapy. We need more information here. This is the NCCN, a little bit different table here, listing off our different medications, include a preferred and subsequent line therapy. 2 points on this slide is FOLFOX therapy, even though it's called category 2B. I haven't seen that used any place in the United States. Subsequent line therapy, we've got a really hot topic with nivolumab, a PD-1 inhibitor, with ipilimumab, a CTLA-4 inhibitor. And then we have data on cabozantinib as third line therapy. It's really the only drug where we have good data about third line, although any of these could be considered as third line therapy as well. I'll get to ramucirumab in a moment. So targeted therapies, this is a nice graphic about where these different medications work. And it's really important to think about, especially the oral targeted therapies working at a number of different receptors and a number of different signaling pathways. We will be biopsying more patients. We'll be determining the level of receptor expression, receptor activity, signaling pathways in patients. And that's going to help guide which therapy to use, or conversely, which therapy not to use. I mentioned atezolizumab, super hot topic now as a PD-L1 inhibitor, IPI, CTLA-4, Nivo, Pembro, and ramucirumab is quite interesting, working at these VEGF-R receptors, as well as you're going to be seeing with bevacizumab. I'm going to now change just for a moment to Y90. There's, I think, a misinterpretation of this data. If you look in the literature, both the SARA trial and the Survinib trial, comparing Y90 to sorafenib, were deemed failures. I don't consider these failure studies at all. I think they've added a great amount of information to the literature. And in the US, where I work, Y90 is a super leading option. I understand it's quite expensive and not widely available in India. I'm hoping that can change, but I don't know how to change the price point of producing this radio-labeled either resin or glass spheres. But these studies clearly showed non-inferiority of Y90 to sorafenib. So non-inferiority is very important because the quality of life and adverse event profile with Y90 was substantially less than sorafenib. I've used sorafenib in hundreds of patients. In those subset of patients who respond to sorafenib and can tolerate therapy, we've seen some excellent responses. But Y90 in general has a low side effect profile unless you're treating patients with more advanced liver dysfunction. All right, what about atezolizumab, bevacizumab? This was published in New England Journal of Medicine just a short time ago. We have the 6-month overall survival rate, which still remains as a primary endpoint in our phase 3 studies, with a delta here between 85% and 72%. But look in the upper right-hand corner, the median overall survival, 13 months in sorafenib, but was not reached in the atezo-bevacizumab combination. The prediction from modeling is probably going to be around 30 months. So this is quite impressive and a major change, and has entered into the first drug combination or medicines that I discuss in my patients with unresectable hepatocellular carcinoma, especially those individuals with widespread disease or metastatic disease, but they still need to be Child's B7 or less, And there's a variety of different adverse event profiles you need to know about when using these medications, including adverse events that are immune related. Progression-free survival also, substantial difference at 55% versus 37%. Safety, got to think about what you're doing with these medications. Sorafenib is more somatic, gastrointestinal, skin effects. Atezolizumab having problems with autoimmune events. Bevacizumab with risk for bleeding. So make sure your varices are banded, peptic ulcer disease well managed, and try to avoid procedures. All right, so what about a special population? This is patients who have failed sorafenib, and are we going to be using immune checkpoint inhibitors, or will we be using regorafenib? Now, in second-line therapy, this is almost out of date, because if we're going to be using second-line immune checkpoint inhibitors, we're probably going to be combining nivolumab with ipilimumab. But in the non-progressors in this study, progression-free survival was improved by 50%, or doubled specifically, in patients who are nivolumab treated versus regorafenib. So a strong consideration is in your second-line therapy is to move to a nivolumab ipilimumab combination, where we may see even better overall survival and progression-free survival. Should we biopsy all liver cancers? And I'm going to say yes, although I put a little more conservative statement probably on this, because we have multiple liver cancer profiles. I'm sorry, Professor Vivek, I couldn't come up with a better slide with better resolution here, but I think we have some really good messages here. We've got three different populations here. The right side, the blue side, is this immune active or hot with an inflammatory response. These patients are most likely the ones that are going to be responding to ICI therapy. If you have on the left side a cold type tissue, you may be much more likely to go to some type of oral tyrosine kinase, multi-kinase inhibitor, or ramucirumab if patients have high alpha fetoprotein, which is typical for this left or red category, column 1. So you're going to be getting tissue, you're going to be doing genomics, you're going to be looking at the pathology, you're going to be looking at capsulation, and all this is now clinically and commercially available. What about circulating tumor cells? Well, we don't have commercial assays quite yet for liver cancer, but I think this is coming around the circle. We'll be doing liquid biopsies and cell-free DNA as well. But in this study presented at EASL, mutations in circulating tumor DNA help predict resistance to systemic therapies in patients with advanced hepatocellular carcinoma. They looked at mutational analysis using ultra-deep sequencing and digital droplet PCR, and they looked at progression-free survival depending on mutation profiles. And here we have in the upper right-hand corner, they look specifically at this PI3K mTOR pathway mutations. With mutations, the patients did very, very poorly, and this is after TKIs versus those without, and no mutations, the patients lived much longer. So lack of mutations may indicate a better sensitivity to TKI inhibitors. Wnt pathways mutations were not associated with progression-free survival or overall survival, but we have new medications that are going to be targeting the Wnt pathway, and it may be useful. The left side shows you the most frequent mutations, and this is also going to help guide therapy in the future. We have TERT promoter inhibitors and other drugs that are targeting CTNN, et cetera. So histomolecular categorization can be further complemented. Treatment and prognostic-based HCC categorization. We have histopathology and HCC, this VTEC or this specific pathology with encapsulated tumor. Yes, sorafenib. If you've got this PI3K mTOR activated HCC, probably no sorafenib. If you have an inflammatory type profile, immune checkpoint inhibitors preferred. CTNN mutated HCC, I would not be using ICI therapy. So I'm at all the different places where I work on tumor boards, including Loma Linda, Las Vegas, Reno, San Jose. I am advocating moving to tissue biopsies, as well as a Fresno clinic where I have. Okay, let's talk about something that's another hot topic. Over the last 4 years, I started using statins in all of my patients with cirrhosis, irregardless of cholesterol level. Been very interesting data about decreased risk of liver cancer, improved overall survival, decrease complications of portal hypertension. But this is in a group of patients who had hepatocellular carcinoma, who were treated with a variety of different algorithms and treatment protocols, and the statin users had a much better survival probability. There's also a study that was shown at EASL that patients with higher cholesterol levels had a much higher chance of either recurrence or progressive HCC. So statins are modifying different signaling pathways, in my opinion, and I believe and should be used in HCC patients. And I'm hoping this will enter the guidelines soon. But sometimes we need to move ahead of the guidelines when we have the right data. Okay, what about patients who've had a liver transplant with recurrent HCC? Well, we have data that sorafenib improves survival in those individuals, progression-free survival and overall survival in some small studies. This is regorafenib after sorafenib treatment. So they had to be sorafenib tolerant but progressed, and then were put on regorafenib. And I want your eyes to move to the second to bottom line. Median overall survival in this treatment group who got regorafenib, 14 months. The patients who were sorafenib tolerant but progressed and who were not treated with regorafenib, median survival of 4.5 months. And this reached very profound statistical significance. So think about continuing to treat your transplant patients with recurrent HCC with multi-kinase inhibitors if they're tolerant. Okay, what about hepatitis C patients? They reach an SVR, they're cured. What do you do about monitoring those patients? Do you need to do surveillance? Now, of course, if they're cirrhotic, the guidelines say yes, but we can do into some more interesting risk scores here. And in this study of 206 patients who develop HCC out of about 4,000 patients, 9 variables were associated with HCC occurrence. Men, of course, always worse than women in this setting. Older age, but here any liver synthetic dysfunction also predicted a higher chance of HCC occurrence. This is a study where hypercholesterolemia had a hazard ratio of 1.75. That's kind of interesting because it may be a signal of what's going on inside the hepatocytes that may be promoting cancer in some way through lipid signaling. Genotype 3 we've known about before with hepatitis C, but most of those patients will be cured. But if they were genotype 3 before cure, still a higher risk of HCC. Very interesting. Alpha fetoprotein. Remember I mentioned earlier about a new normal? So I have a reset. I'm thinking AFP 5.5. And above that, I'm going to be really monitoring my patients closely. And I'll be doing the GALED score on these patients, looking across 3 biomarkers and monitoring them closely with surveillance. FIB4 and interferon therapy also influence this risk. This is the HepaTher study that I think was predominantly coming out of the French database, the ANRS. Another standard of care is a multidisciplinary approach to HCC. This is the standard to have all these different individuals directly or indirectly affiliated with your management team. So in wrap up, thank you very much for having me here today. I'd like to highlight that the GALED score is now the state of the art for early detection. LIRADS for diagnosing HCC, biopsy all liver tumors that are not resection candidates as a strong consideration, first line therapy, what I call AB therapy, second line therapy, well, ramucirumab for high AFP patients, cabozantinib I may also be using in patients with an inflammatory type HCC signal, ICI combinations, first and second line are key options, multidisciplinary team, and statins. Thank you so much to all of the panelists, the leaders, co-moderators, and I appreciate being here today.
Well, thank you, Dr. Gish, for an extremely comprehensive overview about the recent advances in this area and giving us a lot of very provocative combinations and newer approaches, as well as monitoring markers. We are running a bit short of time here, and we do had about roughly 15 minutes set aside for the panel discussion. So we'd like to go ahead with the questions as quickly as we can. I'd like to first introduce the panelists. I'd like to welcome Dr. Ira Yu. She is the first Vice President of the Philippine Society of Gastroenterology and heads the Gastroenterology section at the National Kidney and Transplant Institute in Manila. Again, I'd welcome Professor Kin Mong Wing. He is the heading the Yangon GI and Liver Center and is the founder of the Myanmar Gastroenterology and Liver Society and a frequent visitor to India. All of us know Dr. Dhiman. Dhiman is currently the director of the Sanjay Gandhi Postgraduate Institute in Lucknow and formerly the head of Department of Hepatology at PGI Chandigarh. And Dr. Shalimar is additional professor of gastroenterology at the All India Institute of Medical Sciences. And Dr. Setu Babu is a senior consultant in gastroenterology and hepatology at the Krishna Institute of Medical Sciences, Hyderabad. Good evening to all of you. I'll start off with a question to Dr. Ira. If you could please unmute yourself. And I think in view of the shortness of time that we have, maybe you could be a bit pointed in your response. We have heard about the Gallup score for liver cirrhosis and its screening and its high area under the curve or ROC curves. So for non-cirrhotic HCCs, particularly in patients with NASH, NAFLD, what do you think would be a good surveillance approach?
I think surveillance, go ahead, sorry.
Yes, like what Dr. Gish mentioned, I think we will be hearing more and more of the Gallup score in the next few months, next few years. They've been using it with a cutoff value of 0.6, and they found it to be good in predicting HCC, not only among the cirrhotic, but also among the non-cirrhotic, especially the NASH patients. But I guess the big challenge that we face here is really to determine who among our MAFLD patients are at high risk for HCC development compared to the very large number of simple MAFLD. So you see, we need to focus on this high risk identification. And as a start, maybe we can use our non-invasive tests of fibrosis, just like what the practice guidelines have recommended. And from there, we move on to our HCC surveillance. Because right now the guidelines are telling that we do not only do regular HCC surveillance purely for the cirrhotic patients, but also for NASH patients displaying advanced fibrosis.
Thank you, Dr. Ira. I think unresectable large HCCs is a particular problem in South Asia, Southeast Asia. And we have had downstaging approaches of local regional therapies, TASTE, TARE. We heard about yttrium 90 from Professor Gish. My question for Professor Wynn is, how would you choose between using these local regional therapy options or immunotherapy, which we are finding is increasingly effective in these large unresectable tumors? So what in your practice, or what would be your advice? How do you choose between these approaches?
Thank you very much for your question. Local regional therapy, I am very much familiar with the yttrium 90 radioembolization, which is very useful for the downstaging. And I have a little bit of experience with the PD-1 and the CDL4 immunotherapy, which is also not for the liver, but those who have spread outside the liver and the secondaries. I find it very useful. That's my experience. I want to ask Professor Gish, how about the combination of the lenvatinib and immunotherapy? You have any experience or any comment?
So great question, Dr. Wynn. Thank you very much. And Dr. Yu also for your wonderful comments. The answer is those studies are pending, and we will know the role of immunotherapy with TKIs within 6 to 12 months. There's some very large phase 3 studies, and we'll be able to figure out their role, their overall survival, progression-free survival, and the sequencing. And I think we'll sort that out very shortly. I'm very excited.
Thank you very much.
We still have, this is work in progress. Dr. Dhiman, I think you've had some experience with the use of immunotherapy. What are your views about the likely most promising combination, and which do you think will, obviously we await results, but in the meanwhile, what do preliminary results suggest? Which combination of immunotherapy do you think would be leading the race? Could you unmute yourself, Dr. Dhiman?
Am I audible now?
Yeah, that's better.
Thank you, Dr. Saraswat. I think Professor Gish has already enumerated so many the drugs as well as the combinations also. I will just like to summarize. What is the reason for the combination therapy? Because the hepatocellular carcinoma uses numerous mechanisms to evade the immune system. And I would say the attractive approach could be that involving the different combinations. And it could be, as already been said, the two ICIs or ICIs with the angiogenesis inhibitors or ICIs with the conventional therapies such as TACE, and it would be discussed sometime.
Right.
And coming combination of the two ICIs, PD1 or the PDL1, along with the CTLF4, and the studies, I would say that they are pending, they are the ongoing, and the most important studies that have come, they are related to the ICIs and the angiogenesis inhibitors. I would say that atezolizumab and the bevacizumab that has been uh, talked about, and it has shown that hazard ratio for the disease progression as well as for the death is only 0.59. That means there is improvement of about 40%. And if you look at the curves, they show that there is an early separation and which was maintained over the time despite the higher proportion of the patient in the sorafenib group receiving the subsequent systemic therapy also. So coming to the question, answer to your question, I would say that atezolizumab as the bevacizumab is the likely combination which will be used as the first line therapy in the
Right.
advanced or the unresectable
That's what
combination.
Professor Gish's slides also showed. Atezolizumab and bevacizumab seem to be
Yes.
the promising first-line therapy.
My experience has been with the pembrolizumab and the lenvatinib. I would say it was excellent combination, and we got the good result because the number of the patients were small. So I won't say it is just in a personal experience. And coming to the second line therapy, as I already been told, that the nivolumab is better than the rogafarinib, and
Right.
then the combination with the ipilimumab, that is also, I would say,
The
the have
second line
promise.
therapy also combinations you are mentioning, these would be the future combinations.
Yes, yes, it
First
could be
line.
the future
You
combination, but more
need the
data is
results of
required.
therapy.
Yeah, I would say this much only. Yeah.
Thank you. I think a quick word from you, Professor Shalimar. We've heard about the newer approaches of combining histologic and molecular markers, particularly in liquid biopsies on tumor cells. So could you tell us what the future holds for this approach? Because this looks quite non-invasive and very promising, although high-tech. What are your thoughts on this?
I think in contrast to the progress made in other tumors management, where now we have specific drug therapies based on the histology and molecular or genetic markers, we lack similar therapeutic approaches in HCC. The data shown by Professor Gish looks very interesting. The diagnosis of HCC actually is based on imaging, and we've moved away from liver biopsy. So we need to now explore whether histology, imaging, and look for biomarkers in the liquid biopsy to potentially find signatures which can predict the response to a particular drug. Say, who would be an ideal candidate for a TKI, immune checkpoint inhibitor, a combination of drugs and interventions. So this is a step towards precision medicine, I think. And we look forward to larger samples across etiologies and populations. My question to Professor Gish was that in the data which he showed regarding the markers, has it been looked at across etiologies or what different population you studied? So were there any differences across these groups?
So differences in terms of outcome has not been determined, but mutations are very different around the world. And there's a slide deck on my website that talks about mutations by geography. So I would say go to my website, download that deck, okay?
Thank you. Okay, thanks, Shalimar. I think finally, Professor Setu Babu, I think just like kind of a peep ahead of where we are today and say regarding combinations of targeted molecular approaches, immunotherapy, and loco-regional therapy, which seem to be the main effective modalities. Do you foresee a place for these combinations, particularly in unresectable HCCs?
I think the answer seems to be a very big attractive yes. Professor Gish, in fact, has shown a comparative data of TACE plus sorafenib. I would probably expect a comment from him about a sequential therapy of TACE followed by sorafenib, which has some marginal benefit than either of them alone. Similarly, if you look at future, because the approach to HCC is multimodal, we have so many tumor receptors. And when you do TACE, in fact, what happens when there is a lot of necrosis, lot of antigens and DNA gets into the circulation. So it is very good logic to add an immunotherapy or some kind of an anti-DNA therapy to the TACE, and it would be a future logical. So whatever Gish has shown the number of drugs, which includes either nivolumab or esituzumab or even bevacizumab, all should be helpful as a sequential therapy. Sometimes you might start before, do a TACE and then follow it up. I would request Professor Gish to make a comment because it's very good logic.
Yes,
So the logic,
Professor Gish.
the logic is there, the data is not for combination therapy yet. So the answer is, here's real life, here is the guidelines. In real life, if we have a partial responder to ablative therapy after TACE, RFA, or both, and the person still has high biomarkers, still has active disease by LIRADs, I'm going to be treating them with another therapy very shortly after that ablation. But combination is different than sequential. We have great data that sequential therapy could be 2, 3, or 4 different treatment works, and it's part of what's called stage migration. So sequential, yes, combination pending.
Well, I'd like to thank you very much, Professor Gish, for a wonderful presentation, all the panelists for their very thoughtful answers. And with that, I hand over to Anil, with apologies for running late. I think we have overshot our time by about 5 or 6 minutes. Over to you, Anil.
Thank you.
Thank you, Vivek. And I'm extremely thankful and grateful to Professor Gish for an excellent presentation in limited time of a very complex heterogeneous topic. I'm also thankful to all the expert panel members for giving us enlightening us about the issues which have been very well raised by Professor Saraswat. With that, we move on to the next third session of the day, that is renaming of the non-alcoholic fatty liver disease to something called MAFLD. To talk on that, we have none other than Professor Shiv Sareen, who is a household name in India and all over the world as a leading hepatologist, and not only in Asia Pacific, but the whole of the world. He's going to talk to us, is changeover from NAFLD to MAFLD, is it for good or is just a question of semantics? Professor Shiv Sareen Parikh. To moderate that session, we have,
Thank you, Anil, and for your kind words and for keeping the spirit of hepatology. I had to change my topic, my apologies, and Anil kindly accepted this change. And I'm trying to do this, I hope it works. Although it's not easy to speak after Bob, but
good morning. Thanks, Professor Liang, Professor DJ Kim, organizers of this prestigious causal, and Professor
what is it running? Sorry.
Pranab, there is some mix-up of the voice.
इसमें मेरा जो recorded message है वो आ रही है. Just a minute. इसमें record वाला इसको क्या करें? कैसे delete कर? Sorry. It's like I bring greetings from ILGPS and nothing to disclose. I would like to briefly touch on NAFLD and why a change and is it good or bad. Currently, we have a spectrum, NAFLD separate and alcoholic liver disease separate. NAFLD, whether it is fat or fat with hepatitis and fibrosis. NAFLD, 24% of world population, and it is expected that this is going to be the major cause of the next century. This means 2020 and 21. In Asia, alcohol and others means NAFLD, you can see about 40% of cirrhosis is now due to these, and liver cancer deaths are also in the same range. When you look at this world, 1/3 in the US or in India is NAFL, and NAFLD is 10%. But now the story starts. 2/3 of diabetics have NAFLD, and 1/3 of cirrhosis have diabetes. So I have been telling this for 15 years, and we wrote few articles that diabetes is a liver disease. We have a fight with endo guys. In Japan, this is a common survey. If there is no fat and the blood sugar is normal, it's not recorded, that is 0. But if there is NAFLD, blood sugar will be abnormal, impaired glucose tolerance in 43%, and if NAFLD is present, new diabetes in 62%. If you look at diabetics, 98% have some kind of fat or fatty liver disease, and diabetes with obesity, 100%. And they have raised ALT or gamma GT. This is the Framingham study, third generation of those of 1940s. Those who had ALT from the beginning, when they grew up, diabetes development was 5 to 20 times. Also, this very important study where NAFLD was followed for 13 to 14 years, 78% of those who had NAFLD developed diabetes or IGT. NAFLD increases risk of diabetes 2 to 5-fold, and regression of fatty liver fat reverses risk to normal. Now, these are very interesting and important data. And NAFLD has raised ALT or gamma GT or SAP. The incidence of diabetes increases. 1 log increase means 10 in the ALT levels or gamma GT. The risk of diabetes increases 85% to 92. So today this guy has an ALT which is, let's say, 15, and it becomes 150 or so. 1 log increase, and you will see the trouble. Simple steatosis plus insulin resistance. So when you look at anybody with fat, please get an insulin resistance done. That will lead you to fibrosis. You don't need anything, just steatosis plus IR. And therefore, every NAFLD, and I do that regularly, screen for diabetes by oral glucose tolerance. The bottom line is it is the fat in the liver which leads to inflammation and drives metabolic syndrome. We have changed, at least in our hospital, normal ALT is less than 30 for male and for female less than 90. As ALT correlates with NAFLD, dyslipidemia, diabetes, risk of diabetes, as I said, hypertension, heart disease, and its risk and HCC. And this is the famous BMJ study. If the ALT is less than 20, in 142,000 health insurance participants who were followed for 10 years, 90 to 2,000, if these people had an ALT, which if you take 40, the risk of all-cause mortality is 1.7 times, and liver-related 9.5. And if you take ALT of above 100, it is certainly all-cause mortality increases, and so is liver-related mortality. This study which we published of about 1,100 patients who had NASH or cryptogenic cirrhosis, this was the index patient. They had diabetes in 47% of so-called NASH or cryptogenic combined. Their brothers or sisters had diabetes, or parents have diabetes, or son or daughter had diabetes. So diabetes and NASH or cryptogenic cirrhosis, tremendous overlap. If there is a family history of metabolic traits and you go and find in details, the NAFLD or cryptogenic cirrhosis patients, they will have 2/3 of them will have any metabolic trait. So diabetes and liver are very closely related. ILGPS data, I just want you, these are about 988 cirrhotics with diabetes, and these are cirrhotics without diabetes. The only thing I want to say is that those cirrhotics with diabetes have a much worse CTP scores. If you look at development of cancer, those who have alcohol plus diabetes put together, they have a 9 times higher risk. But any cirrhosis, of course, increases, but diabetes with cirrhosis, the risk increases. And diabetes plus ethanol is 9 times. So my first summary is NAFL is in 1/3, diabetes in fact is in 10% of Indian population. Fatty liver predates diabetes mellitus, and especially if it is high ALT. 60% of NAFLD cirrhosis have associated metabolic syndrome. Diabetes, I think, and all of us, if we agree, is a liver disease, and it should be in NAFLD. When you say NAFLD, you will think of diabetes. And if somebody has obesity, liver fat is there. So cirrhosis and diabetes together, higher HCC, and if ethanol is added, it is the highest. Let's look at why do we need a change to MAFLD. It is the ectopic fat and development of insulin resistance that leads to diabetes, hypertension, and etc. And what is an ectopic fat? Ectopic fat is one which is present in the liver, it's in the muscle, it's in the pancreatic beta cells, or in the perivascular area. And all these lead to different diseases. So in an NAFLD patient, you have a dysfunctional adipose tissue, and this leads to going around into the pool. I don't have time just to tell you that inflammatory cytokines and a dysfunctional adipose tissue, which leads to several complications, type 2 diabetes, cardiovascular, and neurocognitive. But remember, genetic and epigenetic, and I'll come to it in a minute, and this is determined by your bacteria and by your adipose tissue. Whole of gastroenterology is now filled up with this. So what is the role of genes? Now, this is your genetic predisposition. I told you in the family history of diabetes, in the family history of cirrhosis, if you have one, the genetic predisposition is less. Here, the environmental factors will play a huge role. Here, there is a genetic predisposition, environmental factors will play much less role. So we have to now phenotype our patients. Where is the genetic PNPLA3 positive or any other? These are guys who have a high genetic predisposition, rapid fibrosis. And that is where the concept of MAFLD has come. I'm not selling you the concept. I'm just telling you phenotypes and genotypes. These are the manifestations. So the question is the person or the environment to be blamed? We looked at this data very carefully in about 760 liver biopsies. Now here is the NASH CRN score. Those people who had a BMI of less than 23 versus those more than 25. You can see that NASH CRN was not different. And here it brings you to the fundamental concept of genetic predisposition, lean or normal weight people with NASH. So I just want to say every fat person is not bad and every lean is not good. So the second part of my summary is this. Ectopic fat is the basis for metabolic syndrome and organ involvement. There are 4 types: lean, metabolically healthy, or metabolically unhealthy. We need to define it. Obese, metabolically healthy or unhealthy. So there are 4 variants. And NAFLD today puts all of them into one basket. And when you say NAFLD, cardiologist doesn't bother about you. Nephrologist doesn't bother. Gynecologist doesn't bother about you. So therefore, it is extremely important for us to include the metabolic part into our NAFLD. And we give a positive diagnosis. just not absence of alcohol, non-alcoholic fatty liver. So I'm making a case for change in name. So let's look at how do we do and what was the process in the involvement. So NAFLD and alcoholic liver disease. Now the new terminology has cryptogenic, it has metabolic, dysfunctional, dysfunction associated syndromes, and alcohol. And here all kinds of hepatic fat which is causing lipotoxicity. So the new term involves all these. Just to give you an idea, this is the US. I thought India was bad. Majority in US drink in 2017, Australia 63%, and US 66% are 4 drinks a week. And if somebody has 4 drinks a week, then you can think he's a moderate kind of a drinker. FIB4 is high and NFS scores are high. So somebody has fatty liver, how many? 1/3 of the population. And 2/3 population might be drinking 4 drinks a week or more. And then if you have such population, you will be excluding them when you have a diagnosis of NAFLD because you will remove them. And that's not fair. I'll give you one example of our study published 2 years ago. Positive family history of metabolic traits in severe alcoholic, early and severe alcoholic disease, a cross-sectional study. 1,084 alcoholic cirrhotics were taken. The family history of metabolic traits was documented again in about 2/3 of the population. What I want you to read with you, patients who had family and personal history, both parents or family or sisters, has metabolic traits have 3.3 times higher risk of having an early age diagnosis and 13.2 times of progression to cirrhosis with lesser amount of alcohol and 4.6 times lesser duration of alcohol consumption. So an alcohol guy who drinks has metabolic traits has a huge challenge. So therefore, it is time to revisit NAFLD nomenclature. And what is it like? One is alcohol predominant fatty liver disease. This is alcohol predominant or metabolic dysfunction predominant. So here is the metabolic function predominant. And of course, there will be a group where there will be an overlap. And this group will depend upon the country and the culture. So this process was started in 2019 of changing the nomenclature, and some of us were involved into supporting a change from NAFLD to MAFLD. Now, what is the relevance? And it is simple. Now you have a guy who has hepatic steatosis. Now, you have to just define MAFLD. So one group overweight or obese, he goes straight into MAFLD. Type 2 diabetes, he goes straight here. And now remains the group where you have to define lean or normal weight. And this is less than 25 or 23, whatever you want, and should have 2 metabolic risk abnormalities: waist circumference, BP, plasma TG, HDL, pre-diabetes, or HOMA of more than 2.5, or plasma high sensitive C-reactive protein, which is high. Now 2 of these, and that makes a diagnosis of MAFLD. So what I want to stress is you don't have to have a major thinking of change nomenclature. It is type 2 diabetes or overweight or obesity and lean, normal weight, but metabolically unhealthy. Now, what is the benefit of changing the terminology? Well, the benefit could be an umbrella trial. An umbrella trial is, let's say you have a guy with MAFLD. He may have a subtype which is not dependent on genes. It is environment. Here you have a different subtype. Here you have a subtype 2 which is dependent on genes. Or here you may have another variant. We need to identify, so these 3 subtypes have been identified of MAFLD. We can do an umbrella trial. The advantage of also is that you can have the patient as a whole. You can involve cardiovascular endpoints, you can involve fatty liver endpoints. And right now we just do a liver biopsy and ALT, but you do not involve other endpoints like diabetes or cardiovascular disease. So this gives you an opportunity of involving the patient as a whole. Moreover, you will have a better public health response. The people will be talking to you, not to just cardiologist or a person with cardiologist or nephrologist. The survey, this is 2019, none of the 29 European countries have action plan for NAFLD because nobody bothers about NAFLD. NAFLD is not in screening guidelines of diabetes. Liver disease are underfunded and nobody includes it into the non-communicable disease. Even asthma, COPD is included, but not liver disease into the non-communicable disease. But every good thing also has a bad thing. There can be caveats when you use an MAFLD. It's a hugely heterogeneous group. Now you have a patient who is cirrhosis in the absence of any typical histology, but who meets criteria of metabolic risk factors. So you will put him into an MAFLD and say, okay, this is an MAFLD. I have my own concerns. I would always do a liver biopsy and actually exclude other causes of liver disease, which are right here. And also, I have a problem if this guy has passed alcohol. He was drinking till 10 years ago, now he has stopped, but he drank for 25 years. Now, the effect of all these onto liver and to convert somebody who was an alcohol user and now into MAFLD will be a huge challenge for us. Of course, there can be overlaps. So my problem with MAFLD is it's a very heterogeneous term and we have to work to define this. So my third summary is we need to define phenotypes, subtypes, and assess fibrosis. And this will help you in real life in having an overall picture. This is a modified protocol which we use at ILGPS. Now, anybody with diabetes, obesity, metabolic syndrome, or mild to moderate alcohol consumption, and this is same as used for NAFLD, nothing very major in this. If the LSM is less than 8, he is low risk. If LSM is 8 or more, he is intermediate risk and should be considered for biopsy, which if it is 2 or more stage, needs therapy. Now, this is a real life situation. Now here, fatty liver in 777 Japanese patients. They taught NAFLD and they removed all the alcoholics and others. The sensitivity of picking fatty liver was, and correctly diagnosing was, sensitivity was 72% and negative predictive was 88%. But when you use NAFLD, you have a good sensitivity and negative predictive. And their inclusion was overweight, obesity, metabolic dysfunction, type 2 diabetes. So what was the advantage? You picked up 20% more fibrosis when you used MAFLD. These guys would never have, when you say MAFLD, you are seeing this whole group, you pick up 20% more fibrosis. And that's the advantage. So to start in 1845, the first time fatty liver term was used, and Ludwig made it into NASH in 1980. Alcoholic fatty liver was out. We divided them into pure fat, fat and fibrosis and inflammation. Now, if you remove NASH, you make it MAFLD, and then you may have subtypes. Of course, it's a huge challenge. Genetics and epigenetics and metabolic, healthy or unhealthy. And this may be the future. The whole of one issue of gastroenterology was on NAFLD. And this starts from unhealthy diet to microbiome to the time you sleep and your metabolic inflammation. And of course, everybody wants to be healthy, but they don't work for it. And then if you have MAFLD, you may end up, or your patient, not you, may end up there. So this is my carry home message. All of us would agree there are problems with NAFLD as a terminology, numerous problems. New name MAFLD is inclusive, But there is no consensus. It is just a newborn baby without actual identification marks. MAFLD includes obesity just by virtue of being overweight and obese and diabetes, and with or without any other metabolic syndrome. Mild to moderate alcohol is included in MAFLD. I'm a bit worried because people will never tell honestly. The caveat is it is heterogeneous. The simple message for me is if you include all these terms and screen that group of patients, you will be able to pick up more patients with fibrosis. It is actually the fibrosis which determines everything. The best part is with MAFLD, the future of hepatology is bright. People will come to you asking for opinion, not to go to cardiologists or other people. Thank you for your attention.
Thank you, Professor Sareen. You have proven Shakespeare wrong by saying that NAFLD by any other name will not be as sweet. So to have a discussion in this session, I have 2 international experts and 3 Indian experts. So we have Ruvina Bhavani Rajaram from Malaysia, Zaigam Abbas from Pakistan, and from India we have Naresh Bansal from Gangaram Hospital, Virendra Singh from PGI Chandigarh, and Katie Shinoy from Trivandrum. Let me ask Ruvina to either make a question or a comment to Professor Sareen's presentation. Ruvina, please.
Thank you, Dr. Samir. Thank you, Professor Sareen. That was an excellent talk. I would like to opine that with the new diagnostic criteria for MAFLD, fatty liver would now be considered as a hepatic manifestation of a systemic disease, which is metabolic dysregulation. So with that, the management would be directed to improving the metabolic parameters, which also helps to improve fatty liver. And as fatty liver sometimes precedes cardiovascular events, this approach could actually help to mitigate cardiovascular risks as well. What do you think, Professor?
I agree. That's what I am saying, and I'm happy you agree with it. You put it so well. I agree.
Zaigam, would you like to either have a question or a comment?
It's always wonderful to hear Professor Sareen. So we in our language say, "नामों में क्या रखा है?" तो गुलाब को जिस नाम से पुकारो गुलाब ही रहेगा. So I think that Dr. Sareen has tried to make a point that नामों में रखा हुआ है, and it appears to be a heterogeneous sort of etiology for MAFLD. So MAFLD may be a better choice of name, but again, I think maybe a good choice of name for tomorrow, but for day after tomorrow, I am not sure whether this terminology would remain to stay there or not. So I think this is another problem is that in Pakistan, we do not see much lean NASH. So in India, when we go through the Indian literature, we find that there are many cases of lean NAFLD or lean NASH. So we tried to find out our data. We could not find many patients, maybe genetics or epigenetics, why this is so. Maybe this is South India where this is more sort of a problem, and how do these patients differ? Because when I go through the literature, insulin resistance is still a problem even in lean NAFLD patients. So Professor Sareen, any comments about that?
Well, of course, what is there in a name? आप पुलाव की बात करते हैं तो फिर हालात बदल जाते हैं. You remember the Pickwickian syndrome? You know, in 1950s, the famous Pickwickian paper. I'm suddenly reminded from Pulav to Pickwickian. And the idea was people would snore at the table, and that was the Pickwickian boy. But the name changed to sleep apnea, obstructive sleep apnea. So changing name defined a subset of 2 types. One, obstructive sleep apnea, which was a separate group, and another group of obesity. I think changing name, if it is for better, and we don't know for MAFLD, if it is for better, I think we should debate for a few years or some time before we accept it. It's just a thought. The idea is to include diabetics and the other extreme of overweight or obese. But Indians do have lean NASH, metabolically unhealthy.
Professor Virendra Singh, very short, quick comment or a question, please. You are mute, you will, yes.
Yeah. As usual, you can't predict what Dr. Sareen is going to speak. In the end, the last moment, he changed the topic. I was supposed to ask questions on ascites and HRS, but I have to ask, see, this term, very well, he is seeing the future. Maybe in future, but it is too early to say. And I'll ask one question to Dr. Sareen. One is that, as he says, that those who have NAFLD, the fatty liver, and then the transplantitis is there, they are most likely to develop diabetes in future. So in that case, are we suggesting that these are patients in whom all those measures, even the prevention of these with some of the drugs as the metformin may be given? Yes, Dr. Sareen.
Yes, you are talking about post-transplant diabetes and metabolic syndrome in a person who earlier had fatty liver.
Yeah.
Well, that's a very good thought. Certainly, metformin is a good drug and it clears the fat from the liver to some extent, not that much. It makes insulin resistance less. To me, inflammation due to fat is a huge area, and we need to decrease inflammation. And for that, there are not many drugs, except to me, anti-TNF and toxifylline, which is a very strong anti-inflammatory. So post-transplant, certainly metformin, if there is a fatty liver, you can give. But whether patient will develop diabetes based on prior NAFL is a good question. I don't know that. I don't.
Professor Katie Shenoy, would you like to comment?
I think it is always lovely to listen to Professor Shiv. I have two questions, one from the point of epidemiology and second from the point of management. In the new terminology, the MAFLD, how this terminology can be used to design a study of the population prevalence of this condition. Number two, you mentioned that using the FibroScan, the value of more than 8 are the ones which require a biopsy, which in our circumstances, it will be approximately 18% of those people in the population. So your comments, please.
Very good, Professor Shenoy. First, anybody who is obese, you don't even have to do a FibroScan, or anybody who is diabetic. So we expect that there will be some grade of fatty liver. And fatty liver, as you know, is more than 5% of fat in the hepatocyte. So it is proven beyond doubt, and that is by your MRI, when you do the MRI fat estimation, proton density fraction, so it shows. So now obesity and diabetes are part of the fatty liver. Now, in a general population, how do you study the epidemiology? I would say you look back. It's like first fatty liver, then you say, okay, you're drinking a lot, you're out. Otherwise, mild and moderate drinker, diabetics, and those who have fatty liver due to obesity are part of it. So it's a huge challenge, but we are working on the subtypes of this and genotypes and subtypes. But I think it is easier to diagnose a fatty. It's like measuring blood pressure. You know, fatty liver, 3 of the 4 things are present in him. It's as simple as that. When you look from a public health perspective, you would be the most happy. Fatty liver, fibrosis, grade 2, you are in. You are for a trial. You are in for treatment. As simple as that. No third question. No ALT, nothing. Now, the need for biopsy. Liver biopsy in more than 8 is generally advised. I do all my patients, we do about 1850 liver biopsies in a year. I would do a liver biopsy is if there is a lean NASH, certainly lean guy and has fat, I would certainly do. Obese guy, I will say wait. If you can reverse and fat can reverse, so can be fibrosis. So I would give 3 to 6 months time for him to lose. And very recent and very interesting study, if you give very low calorie diet, that's 600 calories per day, the patient can lose in 3 months time fibrosis by 1 grade. It is as good as doing the large, famous, expensive study. So I think I'll give 3 months on a very low calorie diet and see. If not, if he still has, biopsy.
Naresh, a final quick question or comment before we wind up this session.
Thank you very much, sir, for a nice deliberation. And there are very few, in fact, diseases which are basically defined by negative terminology. And now it is good that non-alcoholic fatty liver disease is also being considered as a metabolic liver disease. But still, I think there are a lot of issues with the definition. And in the coming time, we should have some objective parameter by which we can define that disease, so that there is no discrepancy when we are talking about the disease. And second, when the alcohol intake is now so rampant, now it will be very difficult to differentiate between alcoholic liver disease and metabolic fatty liver disease also. So I think we have to progress with the time. Thank you, sir.
So with all this, I'll wind up the session by just saying that the term non-alcoholic fatty liver disease was good for insurance reimbursement. At least it was sure that this was not alcohol. Now with metabolic, still we will have to say whether the alcohol is the cause for the liver disease or not. I think with those words, I'll hand it back to Anil Arora for the rest of the proceedings.
Thank you, Samir, for excellent moderation of the session. I am extremely thankful and grateful to Professor Sareen for trying to rename the so-called negative terminology of non-alcoholic fatty liver disease to giving it some positive component of metabolic syndrome, which may have its own caveat in terms of the etiology, the contribution of the various components of the metabolic syndrome, and obviously the insurance factors as mentioned by Samir. With that, I am thankful to all my expert panel members who have visited from different countries and from India for making this a lively session. With that, we switch on to our fourth and the penultimate session of the day, advances in hepatitis which are relevant to day-to-day practice in hepatology. I'll hand over the proceedings to Professor P.N. Rao, please.
Thank you, Professor Anil, and welcome to all the viewers. And we are going to talk about the recent advances in hepatitis. For this, we have Dr. Ashwini Singhal from USA. He's been Associate Professor of Medicine in the University of South Dakota School of Medicine and Transplant Hepatologist in Avera Transplant Institute. Of course, as a hepatologist, we all know his work in alcoholic liver disease. That is a lead author at the practice guidelines in the ACG, and also is a chair for special interest group alcoholic liver diseases in ASLD. And also has got a keen interest in NAFLD. And also, I was also surprised to know that porphyria also is specifically interested in. And of course, renal injury in cirrhosis. He's been co-editor for the many journals. And he would be talking about the recent advances in hepatitis. For this, we have a 4 panelists, Dr. Professor Y.K. Chawla, professor and former professor in HOD hepatology and former director of PGI, and Dr. Pankaj Puri, director gastrohepatosciences in Fortis Escort Heart Institute, Okla Road, and Dr. Natarajan Ravindran, he is then John Hopkins in the USA, and Dr. Rohit Gupta from AMS Rishikesh, and Dr. Mamoon Al Mehtab from Bangladesh, Bangabandhu Mujib Rahman University, Dhaka. With this, I will first, Professor Ashwini Singhal will talk about the recent advances in medicine in hepatitis, and we will discuss about some of the India-specific issues on these things. Then we can all have the panel discussion. Over to you, Dr. Ashwini Singhal.
Can you hear me all? All right. Let me share my screen here. All right. Can you see the slides? Okay. Good. First of all, thank you, Anil and PN for that introduction, and Anil for the invitation. I'm always glad to be on this very clinically oriented meetings of Sir Ganga Hospital, which Anil organizes pretty well. So I want to also acknowledge that over the next 20 minutes or so, I will be talking mostly updates recently on a miscellaneous number of topics as we go through over the next 20 minutes or so, and try to synthesize the literature so that the attendees have some take-home points on these issues in the management in their clinics when they see these patients. And I will not be giving too much of data, but my own perspective and synthesis on these issues. So all these disclosures, I can guarantee none of them is related to the talk. And here are my learning objectives for next 20 minutes or so. So we'll spend a little bit time on hepatitis C, and the time spent on hepatitis C is going down and down in the meetings, and appropriately with the development of excellent, safe and effective drugs with the availability of DEA. So we'll talk about a little bit on the update. On hepatitis B, we'll talk about tenofovir mainly because it's becoming the treatment of choice in various situations. We'll spend a little bit time on alcohol associated. We're trying to avoid the word alcoholic liver disease, and there's more and more suggested again a name change to alcohol associated liver disease, and it makes sense in this field. We'll have some data on non-invasive assessment of ALD, and also upcoming hot topic on integrated care model with addiction specialists and multidisciplinary teams for ALD. Then we'll have autoimmune hepatitis, how to select your second and third line agents in the management if they don't respond to the first line agent. And then the hot topic, which Bob talked about very nicely on immune checkpoint inhibitors and how the immune related adverse events can affect the liver, causing autoimmune hepatitis like picture and DILI. And finally, one of the main reasons we are meeting not in face-to-face, virtually face-to-face, but not in person, the reason COVID-19 and how we can approach and understand the liver involvement and liver injury in COVID-19 patients. So starting with hepatitis C, and I think all of us have seen this slide, how a turnaround has happened in the last 3 decades from when we were talking about response rate of less than 5% to time. And I'm proud, very much proud to be part of the hepatology community in my lifetime, and that this evolution happened, that we can talk about almost cure of everybody with hepatitis C, over 95% response rate with very safe medications. And these drugs which have come in the use of hepatitis C can target many proteins in the hepatitis C virus, whether it is NS3/4A or protease inhibitors, or NS5A inhibitors or NS5B inhibitors, and various combinations of these, and more than 50 to 60 molecules have been tested in the last, I could say, 10 years or so. And the ones highlighted here in red boxes have reached our clinics to treat our patients. And the various combinations that I have highlighted here, these 5 drugs, and for the sake of simplicity and understanding of everybody, because we recognize these medications as Harvoni, Epclusa, Mavyret, Zepatier, or Vosevi, have reached, at least in USA, and I understand and learn what is the availability of these medications in India when we treat our patients with hepatitis C, and we will discuss in panel about these. And this is a busy slide on ASLD treatment guidance. You are all aware on how to treat these patients. Basically, what I would say, how we can use these 5 drugs in treating our different hepatitis C patients. And you can put your patients in different baskets by whether they are treatment naive, that they have never received treatment, or they are treatment experienced. And the treatment naive patients can again be sub-stratified to whether they have underlying cirrhosis or not cirrhosis. And there could be another basket of viral load. What is the viral load of these patients? The treatment experience could be either experienced with a PEG interferon regimen, which was almost 5 years or before, or direct-acting antiviral agents, which could be experienced with protease inhibitor, sofosbuvir experience, or NS5A experience in the past. And as you can see, you can use these 5 different drugs and treat your patients very effectively in all the categories. One of the other advantage of using one or the other drug could be that you can tailor the duration to shorter down to 8 weeks if you use MAFLD in most situations. And in more difficult situations, you can combine one or more of these drugs with ribavirin, weight-based ribavirin, to treat your patients. I think the most difficult now, which used to be the most easy, is genotype 3 hepatitis C, and this is a problem in India more than in US. That especially when they have an underlying baseline resistance to hepatitis C virus, the strain Y93H, that may be a little more difficult to treat, but there are options to treat those. Well, moving on to hepatitis B, like hepatitis C, the treatment landscape of hepatitis B, as we all know, and this is nothing new, I'm showing you here, but what has happened in the last 4 or 5 years is availability of this new molecule, tenofovir, with the side chain is elafenamide, compared to the older molecule of tenofovir, where the side chain was diproxyl isofemerate, or TDF, and this new molecule is called TAF. And why we need a side chain here is shown over here. As you all know, that tenofovir is very unstable molecule, so you need a side chain to make it stable. And when you take an oral administration of one of these 2 molecules, the peripheral conversion to release the active compound tenofovir to go into the hepatocyte where the action is, it happens much more in the TDF. There is very little fragmentation of the molecule in the periphery for TAF. And that is the reason that why the new molecule, MAFLD or TAF, is so potent that you need a very small dose, almost 12 times less dose compared to the older molecule of tenofovir. And also relevant that you have much more safer profile of MAFLD compared to Viriad or TDF, the older molecule, that there is very little breakdown of the side chain in the periphery. And that was shown here in this randomized control trial of 1,300 odd patients, which was phase 3 study, head-to-head comparison of TAF to TDF. And you can see the 2 major organs where the molecule tenofovir causes side effect in the systematic circulation is bones and kidneys. And as you can see, the TAF compared to TDF in the equipotent dose of 25 versus 300 milligrams was much less effect on bone mineral density and also much less effect on the renal function, causing better safety profile of this molecule compared to TDF. And the last 3 or 4 years, we have also seen tenofovir, typically prophylaxis of a pregnant mother for the baby, if the Hep B DNA is more than 200,000 in the second trimester of pregnancy. We have typically used lamivudine because we didn't know the safety profile of tenofovir. And this, I think, the landmark game-changing study 4 or 5 years ago from Calvin Pan in New York showed very clearly that tenofovir in this population, if you use the drug from 32 weeks of gestation to 4 weeks after delivery, is effective in preventing the transmission. But I think the more relevant part was the safety in pregnant mother, and it was shown that both to the mother and baby, the drug was very safe. So it becomes a drug of choice even in a pregnant mother. And this I showed here a recent study published this week in JHEP by UK, multi-center study in all Caucasians, close to 2,000 patients. And this is not a randomized controlled trial, it is a cohort study. And half of these were treated with TDF and half were treated with entecavir, and averagely followed for 7 years. And you can see there is both the drugs are equally effective. They have similar outcomes, except that even including the hepatocellular carcinoma occurrence at the end of 5 years, you can see almost 5 to 6% in the two categories. But what was interesting in this study, and you can see on the right part, that TDF compared to entecavir was much more effective, and they reached a statistical significance at the end of 5 years in reversal of cirrhosis. In spite of the similar efficacy and the cancer incidence being same, why the cirrhosis is reversed more with TDF compared to entecavir, which is a positive finding, remains to be seen, and opens new chapter for investigations and basic science in understanding the mechanism of action of the drug compared to entecavir. And I thought maybe cover two topics in alcohol-associated liver disease, and I'm going to introduce, because we're talking about name changes, and I'm going to introduce another terminology here, which is an early ALD and an advanced ALD. And the reason I will show you that in the next two slides, why we want to change the term to early ALD and advanced ALD, is that histologically you can categorize your patients with steatosis or steatohepatitis with fibrosis up to stage 2, and they have a very different outcome compared to those who already have an advanced disease with either F3 or F4 fibrosis or even symptomatic alcoholic hepatitis, which we all know has a very high mortality. And the reasoning for distinction of these two categories is also shown in this slide, that compared to other liver diseases, and in this example and in this slide, the example is NAFLD, which we might call MAFLD in future, as we heard from the previous speaker. But the point here is that ALD compared to NAFLD in this particular study was at an advanced stage already, and we all see this in our clinical practices when we see patients. But only, not only that they present in advanced stage, but once they present, they progress faster. Whether we talk about presentation with cirrhosis or its complication like ascites or liver cancer. And this translates into a reduced survival even after presentation compared to NAFLD. And there are studies comparing to hepatitis C and other diseases. And therefore, it is mandatory and very relevant and critical to diagnose the disease at an early stage when we have an opportunity to see these patients in primary care with a family physician, and more importantly with addiction medicine specialist when they go for their second disorder of alcohol use or alcoholism or for rehabilitation therapy. And this is the algorithm based on the emerging data on non-invasive biomarkers for stratifying your disease risk. And I've synthesized this in a cartoon and an algorithm here that you can use serum markers like you use for NAFLD. The only difference is that FIB4 is excellent to stratify your patients, or pretty good for NAFLD. It may not be as good for ALD, but it's a cheap marker, easily available. And if this is not available, the other markers which are more accurate like ELF or FibroTest, FIB4 can definitely be used. ELF and FibroTest are more effective and accurate, much more in ALD population than NAFLD population. Whichever marker you used, and the cutoffs are listed here, you can stratify your patients to low to intermediate risk or a high risk. And then you can move on to another sequential marker, which is transient elastography or a fibroscan. And the cutoff used there is 15 kilopascals to stratify your patients to low to intermediate or high risk category. And then once you have put your patient into one of these categories, you can follow these patients accordingly, depending on where your patient fits. When you do an elastography or fibroscan based on availability and a case-to-case basis, you can decide to use MRE or a liver biopsy to categorize your patients. But important thing is, whichever patient you have or whichever basket your patient is, it is mandatory to also screen these patients for underlying second issue which they have, which is alcohol use disorder, and identify those who are at high risk of relapse or those with moderate to severe alcohol use disorder, which I will show you in the next slide. And this is a slide on the other spectrum of the disease, which is advanced ALD. And we all know that availability of drugs for treating ALD are limited. Steroid is the only one for severe alcoholic hepatitis patients, and that also we all know is a suboptimal treatment. But what we know that controlling the risk factor, which is controlling the alcohol use disorder or treating the alcohol use disorder, is the single most effective way to improve their long-term outcomes of these patients down the line. However, the treatment of underlying AUD is very scarcely used, not only in India, but also all over the world. And this is one of the study on the left you can see on patients, about 35,000 veterans. It's a database study. And you can see very surprisingly, and this is an eye-opener actually, that only 14% of these patients underwent some kind of alcohol use disorder treatment, in spite of everybody had that diagnosis claim of alcohol use disorder on the medical chart. And this is a 6 months follow-up data, and only 14%. But what is important on the right-hand side is to see that people who underwent AUD treatment compared to the major chunk which did not receive AUD treatment of any kind had a less chances of new onset of decompensation and a trend for better survival. And that is an important part of the study, I think, is to see and to recommend and develop strategies how we can, in our practices and clinics, develop these integrated care models to take care of the patient simultaneously, not only of their ALD, but also their second pathology of alcoholism and alcohol use disorder. And this is what I propose here. On the left-hand side, you see if a patient has come to primary care with an alcohol use disorder, and you stratify your patients to the risk of fibrosis. And if you find someone who has an advanced disease, fibrosis stage 2 or above, you may like to involve a hepatologist at that time to integrate your management to treat both diseases at the same time. And on the right-hand side is a patient who presents to a hepatologist with an alcohol-related liver disease with an advanced stage, either AH or decompensated cirrhosis patients. And then you screen for an underlying second pathology of alcohol use disorder. As a hepatologist, I think it is our duty to do that. And if you identify someone based on either an audit score or whichever criteria we use, that the patient has moderate to severe AUD, then you integrate with an addiction specialist or a multidisciplinary team to manage your patients and both the disorders. Well, switching gears now, moving on to autoimmune hepatitis. And we all know that prednisone with or without azathioprine is our first-line treatment for autoimmune hepatitis. But I think in the last 5 years, a lot of studies have come up using mycophenolate as a second-line treatment, those who have not treated or not responded to the first-line therapy. And what this meta-analysis of 8 or 9 studies have shown, I've synthesized here, is that mycophenolate is good if the patient is intolerant to the first-line therapy. The response rate is almost 80 to 90%. However, if the patient was tolerating this therapy, but the patient did not respond to the first-line therapy, mycophenolate response is only 30 to 40%. The point here is that if you identify an intolerant patient to the first-line therapy, it may be appropriate to use mycophenolate as a second-line treatment before you move to the third line of tacrolimus or further higher level of drugs. However, if you identify a true refractory patient who have met the criteria that you've reached the highest doses of the first line, it is better to move directly to the third line treatment, with either tacrolimus being the drug of choice in that category. And I think you have seen this slide earlier, and hot topic of immune checkpoint inhibitors. They have been around for about 8 to 10 years now, whether we talk about blocking the CTLA4 receptors or PD-1 receptors or its ligand. But I think as hepatologists, we are not directly exposed. Previously, we were being indirectly exposed to this population because ICI was being used for non-hepatic malignancies. And now with this new study come this year, and Bob showed that very nicely, for treating liver cancer. So we will be directly exposed to these potential patients of 5 to 10% who in the trying to get a benefit of improving the tumor immunology. About 5 to 10% of these patients develop autoimmune hepatitis or immune-related manifestations, and liver gets caught up in that fairly commonly, with causing immune-related delay in these patients. And again, the literature around how to manage delay, not only on other drugs, but specifically to immune checkpoint inhibitors, the synthesis is all there. Once you have made a diagnosis, you can use your clinical judgment, or more objectively, you can use RUCAM, which you can use for any delay, including the ICI-related delay. And you can categorize, once you have confirmed that the diagnosis is more likely delay related to ICI, you can categorize your patient to 4 different grades, depending on the liver enzymes. The cutoff for grade here is 2.5 times, up to 5 times, 20 times, and more than 20 times. And the bilirubin is 1, up to 3, up to 10, and more than 10 milligrams. And if it is a mild kind of injury, which is grade 1, you can continue the drug and follow the test weekly, but you have to hold the drug or ICI for a more severe injury. And then you can move to a more specific therapy depending on how the patient is improving or progressing in terms of your first line intervention of holding the treatment and following the liver test. You can use either prednisone for treatment. We can go a higher level of care by admitting the patient and using a pulse dose steroid therapy, or a higher immunosuppression with tacrolimus, cyclosporin, or whatever you want to use. And the last 2 slides, I will talk about COVID-19. We all know this pandemic, which was declared in early March, and so far almost with a mortality rate of 3 to 4%, close to 1 million population have died across the world, which is so unfortunate, giving us a message that we just cannot mess with the nature. And we are too minuscule and tiny people against the nature when it comes to controlling the universe. Well, we all know that COVID-19 virus infects the cells through the ACE2 receptor, which is also on the liver cells. And then if the immunity of the patient is able to get rid of the virus, either through cell-mediated or even the antibody neutralization, patient improves. However, in a severe disease, whether the inoculum is too high for the immunity to handle, or the patient's immune system is not good enough, it undergoes into an uncontrolled inflammatory immune response with cytokine storm, immune paralysis, development of multiple organ failure, in which liver gets involved also sometimes, but then other organs, predominantly lung, kidney, and coagulation system are frequently involved in these patients. And the last slide to show how we approach these patients once we identify liver injury with transaminitis. And 2 points I would like to make here. Rather than direct injury of the virus to the liver causing transaminitis, it is the other diagnoses which are more relevant, which could be hypoxia-induced liver injury, or shock-induced liver injury, or cholestasis from infections and sepsis. Delay you could be happening from the drugs you use for COVID-19. There could be underlying liver disease, and it makes sense, especially in a population where these diseases, Hep B and Hep C, are more likely. And I think all over the world, depending on which part of the world you are, it's appropriate to screen for hepatitis B and hepatitis C and wait for the full workup until about 2 to 3 months. And if it is COVID-19 related, it should normalize. Otherwise, you can work up for other causes of liver disease. In terms of managing hepatitis B and hepatitis C, in most situations, you will not need that because COVID-19 is very short limited, a month or 2, you would declare the patient of COVID-19, and then you can treat these patients for Hep B and Hep C. Except in one situation, I would caution that if you try to use steroids in a patient with COVID-19, which I think more and more data is coming now in terms of meta-analysis, which is, I think, the highest level of evidence, is that steroids are effective in the most severe patients who are requiring some kind of ventilation. And if you want to treat steroids or use steroids for COVID-19, it is better to suppress hepatitis B virus with tenofovir because there are reports that you can cause reactivation once you stop the steroids. So my take-home points here for the attendees would be that DA availability has made treatment of hepatitis C not only simplified, but also very, very effective and safe. Tenofovir is the drug of choice if available in most situations for treatment of chronic hepatitis B. There is emergence of non-invasive way of stratifying your patient to ALD into different spectrum, and I believe that ALD also has a spectrum of disease. And then strategies are clearly needed to establish integrated models of care in our clinics to handle patients with advanced ALD. Mycophenolate may be a second-line treatment for AIH patients if you document that they were intolerant to the first line, but tacrolimus may be better for patients who are refractory AIH. And when you use immune checkpoint inhibitors for your cancer patients, beware of immune-related bili and autoimmune hepatitis in these patients if they develop any liver injury manifestations, and treat them accordingly on the basis of algorithm we just saw. And then we recognize pathogenesis of transaminitis in COVID-19 patients and how to optimally do the workup on these patients. An important thing here is you want to avoid sending these patients to different departments, endoscopy, ultrasound, try to minimize that. If you need anything, try to get that bedside because you want to avoid cross-contamination and transmission of this COVID-19. And I think I've took enough time. I will stop here, and I look forward to the panel discussion. I think there are excellent panelists, which Anil has collected, and I look forward to learning from them. Thank you.
Many thanks, Dr. Ashwini. And we are going to have some panel discussion on this issue. Professor Ashwini, with your India Connect, because we are going to have some India-specific questions on the recent advances which you have just discussed. Excellent thumbnail summary, given that it is only a very short time of 20 minutes. And let us start with Dr. Professor Y.K. Chawla, and who has been the former director and also now also in the Ganga Institute in Odisha. Professor Chawla, do you think that are we missing the autoimmune liver diseases in our country? And do you think that we have a more seronegative autoimmune diseases as compared to the West?
Yes, Dr. Rao, am I audible?
Yes, yes. Sure.
So, autoimmune disease now is well recognized all over. And I think whenever we do not get any viral markers or any other etiology for acute viral hepatitis, we start thinking in terms of autoimmune hepatitis. This is more often in patients who are females. Those who are jaundiced, they are more likely to be seronegative. For some reason, I don't know. And in acute liver failure, almost 40% of autoimmune patients would not have any serological markers. So I don't have the statistics of comparison, but I think we have a fairly large number, at least in PGI, about 20% of our patients with autoimmune hepatitis are seronegative. And this we diagnose by way of biopsy or looking at a response to steroids.
Thank you, Professor Chawla. In the same vein, I'm tempted to ask Dr. Natarajan Ravindran from Johns Hopkins. He has got an India Connect. He's from Stanley, Chennai. And Dr. Natarajan, why do you think that the autoimmune diseases are less common as compared to the West? Do you believe in this hygiene hypothesis? And Dr. Chawla would remember that even Crohn's disease was a rare disease. In fact, there was an article by Professor Antia, Crohn's conundrum, right? And if any students, he speaks about Crohn's, he's surely to be disqualified. It was so rare in those days. And over the time, we have seen that it has progressed. And is it because of the hygiene hypothesis? Is it because that we have advanced in our hygiene and that's why the Indians, we are seeing these diseases? Over to Dr. Natarajan. And also you chatted, the change in the name of the PBC to PBC. Over to Dr. Natarajan, please.
Okay, first of all, good evening, my colleagues from India, and thank you for inviting me. I think I will share with you my thoughts on autoimmune liver disease, autoimmune hepatitis. Now, autoimmune hepatitis, as we all know, it's a HLA mediated. Now, there's a predominance of, your DRW, 2 and 3, 3 and 4, right? So I'm not sure any correlation between hygienic theory versus autoimmune hepatitis. That is point number one. Even in US, currently, if you look into the current prevalence data, African Americans, we are seeing more cases of autoimmune hepatitis. And also, phenotypically, they tend to behave different. Their response rate to the steroids and the first line is not as good. So in fact, most of my African American patients, they are going to the second and third line of treatment as ASH, as Dr. Singhal pointed out, to tacrolimus. So, and also the African Americans, after the liver transplant, they tend to get recurrence. So there seems to be a genetic predisposition as opposed to any hygienic theory that I would know of. That is point number one. Now, coming back to the primary biliary cholangitis, what currently we are observing in US, the prevalence rate is increasing, as pointed out by a paper that was presented a couple of years ago. Like, if you look into the prevalence rate over the past decade, even African Americans have increased from anywhere from 15 to 30 cases per 100,000, whereas the Caucasians from 20 to 40 cases per 100,000. So we seem to think it is due to the awareness as well as the recognition and also access to the specialist have increased the prevalence. That is point number one. Point number two, the Indian immigrants who have migrated to UK have increased incidence of PBs, primary biliary cholangitis. So the point is it's not only genetic, maybe there is also some geographically, maybe the clustering. And there's an interesting paper that was presented at EASL on the PBC based upon the European data. What they did was they classified north, south, east, and west. And it went through the Amsterdam. It seems like the PBC in the northwest corridor, the phenotypic expression is much different than in the southeast corridor. They tend to respond less to the ursodeoxycholic acid, increased incidence of decompensation and liver transplant. So to make it, to simplify my statement, it's not only the genetic predisposition, and also there seems to be an environmental factor. And I always wonder, how it will be in India if we start screening them, especially with abnormal liver enzymes, with alkaline phosphatase in females. And also, is there any heterogeneity in the north, south, east, and west in the PBC? I would like to, hear from you all.
Thank you very much. And then, as you rightly said, that many of our people, they develop inflammatory bowel diseases, ulcerative colitis. Indian people who move to the UK and USA, and still age autoimmune hepatitis we are seeing now. But I still feel that the PBC is still rare, given that our awareness, maybe that most of the people, they go through the dermatologist. What we find that, a simple alkaline phosphatase would, of course, give a suspicion that this is going to be a liver disease related pruritus. But most of the people, they clung down to the dermatologist for the initial symptoms.
What about AMA negative PBC? Are you guys seeing more AMA negative PBC with, the other proteins?
And what we have seen are AMA2 positive only, but then distinctly in comparison to other diseases, it appears to be rarer. Autoimmune hepatitis, yes, we are seeing that one.
Thank you.
More of overlaps.
Yeah, overlap also.
Overlap syndrome, right. So you are seeing more overlap.
Yes.
Correct, absolutely. With this, we'll move to Dr. Pankaj Puri, who has been with the Army for a quite number of years, and also he's the director of in the Fortis Escort. Dr. Pankaj, you see, DAS, we have only 4 now, SOFO, LEDI, DACLA, and then VELPA. And the Pibrenta, ELBA, Grazo, we don't have them. do you think that it is still an unmet need for us? And given these 4 only, are we satisfied with these drugs? Just we are prolonging to 24 weeks, instead of, and still where ribavirin is possible, then we are giving it. Otherwise, we are prolonging the treatment for 24 weeks of the existing drugs. What's your opinion about this? Pankaj, please.
I never underestimate the Indian pharmaceutical industry. Many drugs have come and many drugs have gone. We had Boceprevir, we had Teleprevir, we had the PROD regimen, including Peritravir. They all came and they went by, and the Indian industry never introduced them. There must be some logic in how they choose these drugs. But that was on the lighter side. But if you look at it more critically, we have most drugs which are available, except the Elbasvir, Razoprevir, and Glecaprevir. These are we have all the rest which are still available. If you look at the Elbasvir, Razoprevir, it doesn't add much more to our regimen. The only one which is really missing is Glecaprevir in the first line regimen. So I'll also stay away from the debate of DACLA, why DACLA is missing from the first line regimen. There are only 2 places we always worried about renal failures and the availability of drugs for renal failure, but now that has been settled and we can use the routine drugs, including SOF, very easily in renal failure as well. The only 2 places where we still have some need or unmet need is the treatment failures and the genotype 3 compensated cirrhotics who have Y93S mutations, where you would probably need to consider using Voxiprevir. And other than this, I think if you ask me one drug and only one which I can choose, I'd probably choose Voxiprevir, even over the first line regimen, recommended regimen of Decaprovir. If I had to choose as a pharma industry, what would I market? I think we aren't too far away from our needs.
Thank you very much. With this, we will go on to the alcoholic liver disease. And Dr. Rohit Gupta is from AIMS Rishikesh. Are we shy of using the steroids in people who are eligible? Do you think that we are not utilizing the steroids as much as they should be used? Because many of us are shying away because of the infections it can lead to. What's your opinion about this? With this, I'll also ask Ashwini Singhal's opinion that how frequently a practicing hepatologist or a gastroenterologist uses the steroids in his clinical practice in people who are eligible. First, Dr. Rohit Gupta, then, of course, Dr. Ashwini Singhal. Over to Rohit, please.
Thank you, sir, for this question. So the indication for steroids will be if your discriminant fraction score is more than 32. But there are a lot of contraindications to use of steroids, like active sepsis, ongoing GI bleed, or a recent past history of GI bleed, patient having underlying hepatitis B and C. So what I feel is that maybe a quarter of patients become eligible for steroids. I was going through, there was a study from Dr. Arora's group where only 12% of patients were eligible for steroids. And then there have been studies from Dr. Sarin's group where around 25 to 30% of patients are eligible for steroids. And with that STOPA trial, which showed only short-term 1 month benefit and no long-term. And then there was a study in Gastroenterology which showed that it increases the risk of infections, and those infections are really difficult to treat infections. So I think clinicians also currently are moving away from using possibly steroids, as a lot of these patients, especially Indian population, we have patients whose discriminant fraction is very high. Especially in North India, we get a discriminant score of 90 or 100. So possibly these patients with the steroids will not be faring that well.
Thank you. Dr. Ashwin, your opinion about this, please, practice, the routine practice in USA?
Right, and I will agree with the comment Rohit just made completely. In US also, the use of steroids is very heterogeneous, not only changing from provider to provider, but also center to center policy. For example, Mayo Clinic shies away from using steroids, and Birmingham and South Dakota, where I practiced after Mayo Clinic, are more liberal in using steroids. But I would say if take a ball game, I would say 30 to 40% would be eligible for steroid therapy in general. It could be more where the practice is more biopsy based, like Lille, where Philmathron and Alex Louvet. There, I think the published eligibility of steroid is about 50 to 60%. So it varies not only across the globe, but within the country also it varies from heterogeneity. And the reasons are very easy to explain because, like Rohit mentioned, you are taking a medication with a very short-term effect of 1 month and then not a long-term effect. And also eligibility based on contraindication and risk of infections. And the risk of infection, which Rohit pointed out in the paper on gastroenterology from the post hoc analysis, you could stratify the risk based on the bacterial DNA level at the baseline among steroid-treated patients. But that's not available in practice to personalize who will, swim away without getting infected the steroid therapy. So there are a lot of catch-ups or hiccups, I would say, in the management, and that explains why there is too much heterogeneity in the use. I think the main point, one of the point is that we all know the lower cutoff when to use steroids, which is discriminant function of 32, the MELD of 20. We don't know the higher cutoff where they lose their effect, or what is the higher MELD score where they lose their effect. And I think from the SIG special interest group, one of the fellow initiated a study which became a kind of an international study from, I think, 17 countries participated in that. The paper is going to be presented at the ASLD this year. And soon you will see that manuscript. It's about 4,000 patients collected retrospectively, where we showed that the higher cutoff where you lose the benefit of steroids is about a MELD score of 37 or 38. And even if you take the number between 31 to 38, the benefit is only 10%. So your real population where you get the maximum benefit would be a MELD of between 20 and 30. And how that translates into a discriminant function, I don't know the answer of that. But if you stratify based on MELD score, 20 to 30 will be your ideal population. 31 to 37, maybe 10% benefit, but after 37, you lose the benefit. And so that is what that study showed from a lot of about 4,000 patients. So I don't know.
Just one comment.
Yeah, please go ahead, Dr. Natarajan.
Just one comment. I think at Baltimore, at Hopkins, we do have a protocol. I think, Ash, you might know, we are transplanting acute alcoholic hepatitis. In that protocol, we do put them on prednisone. And if they don't meet the Lilly score, we transplant them, so right. And you are right, Ash. I think, the MELD above 40, they just don't do well, right? This is the observation.
Yeah, thanks for,
Thank you for the last question.
Can I make a comment?
Yeah, brief comment, because we are going
Yeah.
Please.
It is not that we don't use the steroids. We have used it n number of times, and whenever we have used it, our patients die very early. They go into sepsis. And this may be the reason, because we are ruling out any infection with all possible measures. And then after that only we are using and in some patients, we even did the liver biopsy. This was a classical of alcoholic hepatitis. And even in them, the problem was that the MELD is, the MDF is quite high in these patients. And MDF is beyond 50, 55. So probably that is the reason, as Dr. Singhal is saying, that we lose the benefit if the MDF is quite high.
Thank you. I think that the message is that we have to be highly selective in seeing, which one is. As a last question, last discussion point is to Professor Mamoon. I mean, he's been a distinguished hepatologist from Bangladesh and he's from the Bangabandhu Institute. When you see the fibroscan, you know, we all nowadays we are seeing very frequently every places we are getting the reports of it. Right side, okay, the KPA values, but what to do with the cap? What does it really, what are the cutoffs, you know, out of which, you know, in either in terms of a diagnosis or progress, you know, as we patient loses, you know. What's your opinion about the controlled attenuation parameter?
Thank you. Probably we don't yet have a clinical application of CAP because the fat content of the liver, as I understand, has no relation with the hepatic fibrosis. But I think CAP is important. That is, as you were saying, from our part of the world in clinical practice, maintaining compliance is a very difficult challenge. And lifestyle modification is an even difficult challenge for these patients to achieve. I have seen in my clinical practice that CAP is something that a fatty liver patient is most interested to learn. He or she is not bothered about KPA, that we are bothered about. He or she wants to know after 6 months or after 1 year of follow-up, how is the liver, has the fat decreased or whether it has increased or not. And there I think CAP has an important role to maintain or to keep them adhere to the strict compliance that they need to maintain. Regarding the accuracy of CAP, you are absolutely right. It's a very sensitive machine, and since it is monopolized to some extent by one manufacturer, what happens is, at least in our part of the world, what we see is that the services are not good, the maintenance is not so good. So, like the extreme widespread use of ultrasonogram in the Indian subcontinent, sometimes the confusion, what we feel in Bangladesh at least, is that this widespread use of fibroscan and the not so accurate results sometimes become very confusing. Although KPA should be very accurate, sometimes we find that even KPA is not curative clinically or with CT scan, and sometimes it's a big challenge. So this is the area that remains a challenge. But if you ask me to summarize, I will say that yes, I see a role of CAP in my clinical practice. And before I conclude, I must thank Dr. Anil Arora for maintaining the heritage. It had become a practice for us to be in New Delhi in the first weekend of September for this meeting. We were missing the meeting, but at least that is being held virtually. And hopefully next year we'll be there again in Delhi during this weekend. Thank you very much.
With this, I close this session. I thank Professor Ashwini and all the distinguished panelists for their contribution. And over to Professor Anil Arora. And then you've shown yourself that not only in this one, even in the virtual, you are the boss. Over to Professor Anil, please.
Thank you, Dr.
Thank you. Thank you, all of you.
Moderation of the session. And I'm sure all of you would agree that till the COVID lasts, I don't think we need to read anything about hepatitis. Dr. Ashwini Singhal has given us a gist of what is happening. And till the COVID is over, you can relax about advances in hepatitis. With that, I'm thankful to the expert panel, Dr. Ashwini and Dr. Rao, for making this session very lively and very practical. With that, we finally move on to the last session of the day. It is last but not the least, and there can be no hepatology forum which does not talk of the perfect treatment for end-stage liver disease, that is liver transplantation. To take you through the journey of liver transplantation and its advances over the last few years, I have a very dear colleague, Dr. Dharmesh Kapoor, who is going to talk to us about the way we look at the recent advances in hepatology. Dr. Dharmesh, please.
Good evening, everyone. And like has been mentioned umpteen number of times this evening, we all actually owe this to Dr. Anil Arora to keep the tradition alive of holding this meeting in the first fortnight of September. And he had already sounded all of us that this would take place. And again, trying to get a little ahead of myself because this is the last session. So, sir, we will need your permission to carry on the discussion for some time longer. So in the next few minutes, we'll have Dr. Sanjay Satpathy. Actually, Sanjay and myself, we share our alma mater from GB Pant. And Sanjay is going to be talking about recent advances in liver transplantation. Right at the outset, I would like to introduce the panelists, actually, who are all very familiar to you. They are the usual faces which you see in most liver and transplant meetings. We have Dr. Taneja from PGI Chandigarh, Dr. Neeraj from Medanta, Gurugram, New Delhi, Dr. Neerav from Indraprastha, Apollo, New Delhi, Dr. Naimish from Sir Ganga Ram Hospital, New Delhi, And we have one overseas faculty, which is Dr. Sudhanshu from Kathmandu. Welcome, sir. And with this introduction, I hand over the proceedings to Dr. Sanjay Satpathy.
Thank you, Dharmesh, for that kind introduction. I've been asked to talk about what's new in liver transplantation. So good evening, my colleagues from India and elsewhere in the world. Let me make sure that my screen is visible. Is it?
Yeah, we can see it.
We can see it. Okay, great. So I have really nothing to disclose that is relevant to the contents of my presentation. I have divided my topics into several subsections, which I thought are relevant over the last 2 to 3 years. That is what I was asked to point out. And some of them may be not immediately relevant in Indian scenario, and maybe it will be relevant, and we would like to discuss this with our panelists, and we'll see their inputs. The first I would like to talk about hepatitis C infected donors to hepatitis C negative recipients. It used to be a big problem for transplanting hepatitis C patients, especially the treatment regimen was so cumbersome in the past, but since 2014, things have completely changed. And it also allowed now to transplant hepatitis C infected donors to hepatitis C negative recipients. There was a lot of hesitancy initially, but this was a study that first we published in the setting of kidney transplantation. I thought it was very relevant. Then I'll move on to the setting of liver transplantation as well. Published 2019. This was a single center study. 53 recipients, they were treated with DA regimen that was initiated when the FcRNA was detected after their transplantations. Their mean age was about 53 years. So all the 53 recipients become viremic. The majority, 81% of the recipients, did not experience a clinically significant increases that is more than 3 times higher than the upper limit of normal, which gives the safety this way of transplanting. And only one patient actually was in cholestatic hepatitis, again with complete resolution with the treatment with the DA. All the recipients completed the treatment, and 100% were HCV RNA negative and achieved a 12-week sustained virological response. Since it is a kidney transplant scenario, they also looked at the GFR, and they were, as expected, was not significantly reduced. There were 4 recipients who developed acute rejection, and they needed treatment. Looking at this, the upper panel, you are looking at the AST values and the ALT values, and the lower panel on the left side, you have the hepatitis C RNA. As you can see, there was a significant improvement in the AST and ALT immediately after the treatment, which was well expected. On the right lower panel, you're seeing the time of the transplant, what was their AST ALT level. Obviously, it wasn't that very high. And the start of the treatment, where because there was a delay between the time of the transplant to the time of the start of the treatment, there is obviously a flare of the AST and ALT, and this significantly started improving, and they did achieve 100% of them achieved SBR12, as you can see. Now I'm going to translate this. Then this has immediately was translated into the liver transplant scenarios as well. This is a data that we pulled out with Dr. Thuluvat from the UNOS database. And what you can see here on the, if I can draw your attention, there was this 210 patients who have the recipient with hepatitis C virus negative recipients. Now we can just go this panel. If you see the donor hepatitis C antibody positive in the upper panel, and the donor hepatitis C antibody negative, and then you can they received either the donor was NAT negative or NAT positive, and similarly NAT positive or NAT negative in the lower panel, as you can see. And let me draw your attention to the right side, this figures. You can see in the upper panel what we are looking as the patients who are hepatitis C virus negative recipients, and they are either receiving donor NAT negative or donor NAT positive, and you can see there was no difference in the graft survival or patient survival. In the lower panels, these are patients who are hepatitis C virus positive recipient or negative recipient receiving hepatitis, donor NAT positive organs. And you can see if the patient received the donor NAT positive and are hepatitis C positive, they have a slightly better survival as compared to donor NAT positive and hepatitis C negative recipients. The p-value was 0.049, almost approaching similar results. So this brings to the question, how safe is hepatitis C positive liver transplant in hepatitis C negative recipients? Certainly this has opened the floodgate, and now we are able to utilize this hepatitis C positive livers quite, in a large pool of patients across the United States. And I think this has been the scenario also in India, but I think this is something that we need to discuss in Indian scenario, because mostly since it is a living donor liver transplant situation, I think I do not know, I would like to hear the panelists' view on it. But as we move on and the deceased donor liver transplantation is expanding in India, I think this will be relevant at that point. And we would like to hear their opinion at that point. Second, I will move on to COVID-19 and the liver transplant scenario. This is a paper we just published in Hepatology. This is a meta-analysis looking into elevated liver biochemistries in patients with COVID-19. This was all the studies were pulled was from China very early in the scenario, very early in the pandemic. This data was pulled. But what is relevant, and this has been shown in multiple meta-analysis that has been published afterwards, that as compared to mild cases, patients with severe and critical illness with COVID-19 infection have increased comorbidities like coronary artery disease and cerebrovascular disease and COPD, etc. And also there was a significant association between severe and critical COVID-19 infection with increased AST, bilirubin, and reduced albumin levels. And also I want to point out that the next question that is very important is whether the prevalence of chronic liver disease is higher in patients with COVID-19 positive as compared to the negative population, and the answer is no, there is no difference. But however, the presence of chronic liver disease was significantly associated with more severe COVID-19 infection with the overall increased mortality of almost 1.78 with the pooled odds ratio of 1.78. Additionally, there is also a non-significant trend noted for increased ICU admissions and need for invasive mechanical ventilation among COVID-19 patients with chronic liver disease. I think this is relevant in this scenario as well. Now, moving on to patients with solid organ transplant recipient. This is a study that was very recently published. 90 patients. Of course, I would like to point out there are very few studies only had looked specifically into the liver because the number of patients in this short time period has been very less. And I think more and more papers will be coming out to answer this question. But looking into the overall in the solid organ transplant recipients, this is 90 patients that were analyzed. 46 were kidney, 17 lung, 13 liver, 9 heart, and 5 dual organs. I would like to point out in this, just summarizing the study, that in this initial cohort, the transplant recipients with COVID-19 appear to have a more severe outcomes. And actually, if you look at 24% had mild, 41% had moderate, and 27% have severe disease, and 12% require non-rebreather, and 35% require intubation. So definitely these patients are having much sicker and more critical illness when they are infected with COVID-19. So this fear or anxiety actually has led to significant decline in the number of transplant across different countries. This is a study that was pulled out from Europe and United States. As you can see, there was a sharp decline in the number of organs being transplanted, but that has slowly started recovering, especially in Italy and Spain, where the COVID-19 has been very well controlled now. And we hope that increase in the transplantation has also started in the United States and the rest of the world as well, where the COVID-19 has been more contained. And again, I would like to hear from our panelists and what in the scenario of living donor liver transplantations, how in India they're handling, and what are their thoughts at this juncture. This is an approach to liver transplantation during COVID-19 that was published in Nature Review Gastroenterology and Hepatology very recently. And they have these suggested approaches pretty much, I think, applicable across the world. If you have an acceptable organ, you're looking for the feasibility, and then you're looking at the factors that could increase the risk of COVID-19 in the donor as well as the recipient. If the donor, in the donor, you're looking for a PCR test for COVID-19. Also, you're looking for epidemiological and clinical screening you are doing. So the epidemiological screening includes travel or residence in a high-risk area or contact with suspected cases of coronavirus disease within 21 days before, or contact with a confirmed case of COVID-19 with less than 28 days before. And the clinical screening includes onset of symptoms 21 days before evaluation, that is with fever more than 38 or malaise or flu-like symptoms, new cough, shortness of breath, unexplained abdominal pain, nausea or diarrhea, or loss of sense or taste of smell. These are all CDC recommended screening tools, clinical screening tools. So if those are both are positive, the epidemiological and clinical, that's called high risk. And if the one is positive, intermediate risk, and both negative, then it's low risk. Based on that, they have approached that if the patient has a PCR positive, of course, you're going to discard the organ or delay the liver transplant for more than 28 days in the living donation scenario. But if it is negative, then you are looking for whether in the living donor or the deceased donor liver transplantation, you are entirely relying on the clinical and epidemiological screening, looking into both positive, then you discard the organ. If it is one positive, organ procurement likely safe, and both negative organ procurement of course will be safe. So similarly, I would not go to all these details, but when the tests are unavailable, they also given an approach that you can rely on this epidemiological and clinical screening to some extent. Of course, they are saying you can judge if there's only one screening is positive, case by case, you can choose the planning. But if in the recipient, however, if their PCR is positive, we always look for a backup patient in this scenario, especially in the deceased donor liver transplant. And if there is PCR is positive, then of course you do not proceed with the liver transplantations in the recipients. Moving on to the next topic, which is the liver transplant and obesity. Again, this is always a hot and a contentious areas, especially when the NAFLD and NASH prevalence is increasing across the world, the prevalence of obesity is increasing across the world. We are now trying to be more smarter, trying to find out how we can give a better outcome to these patients. And that is also this is also contentious because many studies have reported differently their outcomes in obese patients. So one of this concept that has evolved over the last few years is the frailty or the sarcopenia. And this is a score that has been published recently. It's the liver frailty index score, which essentially is a combination of scores related to grip strength, chair stance, and balance testing. The grip strength is a mean of 3 trials in the patient's dominant hand using hand dynamometer measured in kilograms, and chair stand is measured at the number of seconds it takes to stand from a seated in a chair 5 times with the patient's arms folded across the chest. And the balance testing is measured at the number of seconds that the patient can balance in 3 different positions for a maximum of 10 seconds each. And this score is available. There's a calculator online. And the standard cutoffs were used to define if the LFI is less than 3.2 is the pre-frail and the frail, and then the LFI is 3.2 to less than 4.5 is pre-frail, and the frail is more than 4.5. The robust is less than 3.2. So with this, this has been validated in a recent study that was published in JAMA Surgery. I thought it is very important. 1,108 liver transplant recipients, 290 were frail, 170 of the 670 non-obese candidates. In their population, 64 of the 246 candidates with class 1 obesity, 56 with class 2. They were frail. So that's a significant percent of these patients had 29%, as you can see, and 26% with the class 1 obesity are frail. the frail non-obese candidates and the frail candidates with class 1 obesity had high risk of waitlist mortality compared to their non-frail counterparts, and the candidates with class 1 obesity when they are compared to. However, frail candidates with class 2 or greater obesity had a 3.2-fold higher adjusted risk of waitlist mortality compared to non-frail candidates with class 2 or greater obesity. So frailty assessments may help to identify vulnerable patients, particularly those with BMI more than 35, in whom the clinician's visual evaluations may be less reliable to assess the muscle mass and nutritional status. So question is, can we put all these obese patients into one basket? Probably not. And we should actually look into this, their frailty index, and possibly these patients can have a much better outcome when we assess them more carefully, and not just go by the BMI in this patient. And also BMI is so difficult in these patients when they have ascites and edema and all, they will always have a higher BMI, and it is very difficult to assess true BMI in these patients. So looking how important is this BMI? This is a meta-analysis just published, and I want to point out this review included 24 studies comprising 132,062 patients. As compared to controls, mortality risk was increased at all time periods, except for at 3 years with a BMI more than 40 in this study, and at 30 days with a BMI between 30 to 35, and non-considered time periods between BMI 35 to 40. I have a lot of concern with this particular meta-analysis, because if I can draw your attention on the study on the left panel, I have just highlighted that the largest population that was pulled in this was from the NIAR study from 2002, and that's kind of driving this entire results. We actually had done another, with the same UNOS data, that was from the UNOS data, we did another analysis looking into etiology as an outcome in these obese patients. So what we did, we compared patients this is a large study with a total patient of 61,000, but we included 39,000 patients after exclusion criteria was satisfied. And almost 2,700 plus patients were NAS patients, and 30,000 plus patients were non-NAS. So we divided and compared this group for NAS patients and the non-NAS patients. And what I would like to draw your attention, that patients in the upper panel, you can see the odds of overall death in the non-NAS group is significantly higher as they progress from normal, overweight, class 1, class 2, and class 3 obesity in the non-NAS group. However, in the NAS patients, surprisingly enough, the odds of overall death was lower as we progress from overweight, class 1, class 2, and class 3 obesity. This is the same in the graft failure as well in the bottom panel, as you can see. And the explanation for this is not quite clear, but I mean, number of speculations can be made, because this is completely an observation retrospective study. Whether there was a careful selection was done because of multiple comorbidities in this group of patients, or whether hypothetically, what I think also may be relevant is that in NAS patient, the central pathogenesis that causes NAS is the insulin resistance. So you are improving insulin resistance by increasing glucose utilization and peripheral glucose disposal once you transplant these patients. So I believe this might have been translating also to an improved outcome, specifically in NAS patients. But again, this needs to be proved in future prospective studies. But this is a very, this is a paradox, and I think I would like to again hear from the thoughts from an Indian scenario, because I have several meetings when I attended. I think the obesity criteria has been quite lax in India. If I'm wrong, please correct me when we discuss in the panel discussions. This is also, again, I want to just reiterate this from the same study. If you look on the NAS group and non-NAS group, look at this is the unadjusted Cox, unadjusted Kaplan-Meier survival. On the upper panel, you have the normal, the red lines showing the NAS patients there. They are the worst survival with the normal group as compared to the class 3 obesity have the best survival on that group. You can see this. And the right panel, so the non-NAS groups, that's the non-NAS patients have the worst survival, and the class 3 obesity patient have the worst survival. Again, this could be also related to multiple factors, because if this may be related to the obesity with additional insults, like they may have hepatitis C, they may have hepatitis B, and many other factors. So NAS, these patients, although been transplanted as a non-NAS like hepatitis disease, but they may have multiple other factors that might be playing a role in those scenarios. I just want to, not going to the nitty-gritty of this particular slide, but just want to show the importance of the bariatric surgery in this scenario to make a better outcome. What I would like to point out is the complication rates. So this is actually looking at the pre-transplant bariatric surgery, then SLT during surgery and after. So you can see there's a fair number of patients that say complications related to bariatric surgery when they're having transplantations when they're having bariatric surgery before their transplantations. Again, these studies are case series and not controlled. And but at least what I can tell, that number of complications that may need to be taken into considerations when we are considering bariatric surgery. This is the advantages and disadvantages I've summarized with different types of bariatric surgery. We're talking about sleeve gastrectomy. The advantages are the gastric functions are maintained. There is a significant weight loss and the resolution of obesity comorbidities, and there is no issues with malabsorption. But the disadvantage is possible bleeding or leakage from the staple line. In the Rho and Y, there is a significant weight loss and resolution of obesity comorbidities, but there is higher complication rates and malabsorption of certain vitamins and minerals. The gastric band is minimally invasive and reversible, but there is relatively less weight loss with high rates of complications. In the biliopancreatic diversion of the duodenal switch, there is a significant weight loss and resolution of obesity comorbidities, but the disadvantage is the highest rates of complication and severe malabsorption in these scenarios. So with these things, we need to keep in mind when you are considering the types of surgery and the specific time when we are doing considering this type of bariatric surgery. So if you're talking about before liver transplantation, the advantage of going for a bariatric surgery is a decreased weight and resolution of comorbidities before transplant, benefits of remaining that persist after the transplant. But the cost disadvantage is increased cost with two separate hospitalization, increased patient discomfort, delay of the transplantations. And during transplant, of course, is a very complex procedure, but the minimizes the cost of the patient and discomfort and the resolution of obesity-related comorbidities after transplant. Dr. Julie Heimbeck from Mayo Clinic has been a big advocate of this surgery during the transplantation. And after transplantation, again, this is decreases obesity-related comorbidities, but there is an increased risk of wound dehiscence and infection in the setting of post-transplant immunosuppression, especially if the patient on everolimus or mTOR inhibitors. And there is also increased adhesions because they already have surgeries done. So there is increased risk of adhesions and the related complications to that as well. I'm running to the next topic, which I would like to highlight about the MELD score and ACLF score. Their role at this point in terms of selecting out patients who will benefit. So the question is futility. Who would be of maximal benefit with the liver transplantation? This MELD score relies on the bilirubin, iron, creatinine, and the ACLF score relies on the organ failures in addition to this bilirubin, iron, and creatinine. If you combine these two, can we predict an outcome? Can we predict the futility of their transplantations? If you can see, this is a single center study. This was a study that I published from Memphis last year. And what we have shown that as in 825 patients, after excluding patients who had SLK, the 589 patient had no ACLF and 101 had an acute on chronic liver failure by the CLIP ACLF criteria. As we progress from non-ACLF to ACLF 1, 2, and 3, you can see there is a reduction in the survival. But it is still not bad. As you can see, 75% patients still can be rescued in a patient with an ACLF 3. Now the question arises, who of these patients would have a worse outcome? Now, if I first combine them with a MELD and ACLF, a combination, if you see the low ACLF and low MELD has the best outcome, and as you progress, the patient with the high ACLF and high MELD and the high ACLF with the low MELD has the worst outcome. So what I'm trying to point out here is that ACLF in patients is the driving factors of their outcomes. So patient with high ACLF high MELD and high ACLF, even if you have a low MELD here, we thought about less than 30 as the cutoff, has the worst prognosis. Again, as the number of organ failure increases, they also have a worst outcome. This is a study from published in Gastroenterology very recently, last year by Sundaram. Again, reiterating the same concept. And you can see the color-coded bars are the MELD less than 25 with the orange, the gray with the 25 to 29, the blue is 30 to 34, and the green one is more than 35. So if you look in the patients with the no ACLF, ACLF1, ACLF2, and ACLF3, I would particularly want to draw your attention to ACLF3. You see even if the MELD less than 25, ACLF3 has there is a significant increase in the death or removal within 90 days of listing. So the ACLF, it looks like, is a driving factor of their outcomes. And this is important and further dissected out in another study, in the same study actually, looking into whether the patient was on a ventilator. So 1 year post-transplant survival, according to presence of a mechanical ventilation at transplantation among patients with ACLF3, particularly the ACLF3 groups, you can see there was a significant worse survival. And this is further dissected based on the DRIs particularly the last one I want to point out, the figure D, 1 year post-transplant patient survival among patients with ACLF3 were mechanical ventilated at transplantation, stratified by transplantation within 30 days versus more than 30 days. So if they're transplanted too early, they have a better survival. If they're prolonged on the ventilation, they look like have a worse survival. I think these are things that we need to consider when you are talking about futility for transplantation. Even there is another study that actually looked into a score. This was by Asrani's group. They actually identified 5 recipient factors, and those are ventilator support, a recipient has more than 60, and preoperative dialysis, preoperative diabetes, and creatinine preoperative more than 1.5. These 5 variables, when they put at different scores, as you can see, ventilator has been weighted very high, 5 points, followed by their age and the preoperative dialysis at 3 and 3 points. So when you add these scores, and they have found that in recipients with more than 8 points, the graft survival was 42%, even if in MELD 25, and 50% MELD 25 to 35, if the donor had a DRI more than 1.7. So again, this is again, if you look at the graft survival within 5 years based on points, 77% from 0 to 4, 69% 5 to 8, and 57% more than 8. So this could be utilized when you are choosing the candidates for transplantation as possibly as a futility score. Again, I would like to just highlight as a passing by that in the Indian scenario, in a PASL ACLF Research Consortium score is also quite useful in terms of predicting mortality or and a score more than 11 at baseline or persisting in the first week was often seen among non-survivors, and this has been compared to the other scores, and they do fairly robust performance. Then again, I would like to bring your attention to another new evolving concept in the normothermic preservation in liver transplantation. This is a study just published in Nature. 2 years ago, it was published in Nature. Number of livers that was randomized, 335 patients. It's a randomized trial of normothermic preservation in liver transplantations, 170 in the normothermic and a standard of care solution with 164, standard cold preservation solution with 164. I would, without going through much detail, just want to highlight how many patients successfully transplanted was 121 on the normothermic perfusion and 101 in the standard cold preservation solution. So the discard rate was significantly less, 16 on the normothermic versus 32 on the other side. And the overall outcomes are not too different, but I would like to point out some very important points with this perfusion. So again, let me give a little bit background of this normothermic perfusion. Now, as you see, donors, over the last 30 years, there's a little progression in terms of the cold preservation. Been using the same solution, the Wisconsin solution. So what it does is cold storage, you are trying to reduce the activity of the injury. But what is happening is the anaerobic, you are almost 10 to 12 fold, you are reducing the metabolism of the liver cells by putting in a cold storage solution. But the anaerobic activity continues, and the succinate and all different metabolites keeps accumulating. And when they are transplanted, the reperfusion, during the reperfusion, there is the oxygenation. When it restarted, there is significant amount of oxygen free radicals are liberated, and this causes the reperfusion injury. Now, with the physiological reperfusion, with the normothermic reperfusion, with nutrients and metabolites and oxygenation, this risk of reperfusion injury supposed to be hypothetically will be much less. And this was what has been shown in animal experiments, and now it's been translated as well in this particular study. So what you will look is a peak AST level with the normothermic perfusion is significantly low, significantly less as compared to the standard of care solutions, even both in the DCD and DVD group, and which is again very surprising. And the secondary outcome that they looked was the discard rates, the primary non-function, and the posterior perfusion syndrome were much less, particularly in the patients with normothermic perfusion. You look at the bilirubin level at days 1 to 7, it was 38.5 versus 49, again, significantly less. Similarly, the other markers, AST, GGT, and creatinine, almost all tend to be improved or significantly less in patients with normothermic perfusion. This is definitely a game changer in the future. As more and more of this normothermic perfusion is being utilized, we'll learn more about it. Of course, this is a randomized study and this is not powered study, but certainly looks very promising and holds promise for the future. Finally, I would like to take a moment to talk a little bit about the alcohol-related liver disease and the liver transplantation. This is again a very, very contentious area. If we have enough livers, we would give every patient an organ offer in the United States. But again, because of the because alcoholics and alcohol-induced liver disease is considered to be a kind of because of self-incriminating disease, there is tendency from physicians to be more stricter in these patients. But I consider a little differently in this group of patients, because see, if we can offer a patient a 50% survival at 5 years, and we are actually doing a good job, even if there is some relapses in those patients. But that doesn't mean that I don't want to look into their relapse, who will relapse, but I would like to find out those relapsers, and maybe we can do a better job in selecting out those patients. So again, this game changer particular study was from Mathurin's group that was published in New England Journal of Medicine. The small study, 26 patients with severe alcoholic hepatitis at high risk of death, they were selected and placed on the list of a liver transplant within a median of 13 days after non-response to medical therapy. Fewer than 2% patients admitted for an episode of severe alcoholic hepatitis were selected. The center used 2.9% of the available grafts for this indication, but the cumulative 6-month survival rate was higher among patients who received early transplantation than among those who did not. The benefit of early transplantation was maintained through 2 years of follow-up, and 3 patients only resumed drinking of alcohol at like 720 days, and another 740 days, and one at 1140 days after transplantation. This led to rethink the concept at this point by many centers. And this particular study, the multi-center study looking into the outcome of early liver transplantation, shows 94% survival at 1 year, 3%, 84% at 3 years. And the relapse rate was 10% at 1 year and is 17% at 3 years. Again, going to the same group actually had also proposed a scoring system looking into what are the predictors that could predict these patients who would have a sustained alcohol relapse after liver transplantation. They found out 4 variables: more than 10 drinks per day at initial hospitalization, multiple prior rehabilitation attempts, prior alcohol-related legal issues, and prior illicit substance abuse. When they give different points, and they weighted it based on a very complex statistical methods, and they found that the C statistics was 0.76 by this score, and they call it a SALT score. And again, this is needs to be valid. There is one study I'll just point out that this has validated that this is a useful tool. But also there is another tool that is the SIPAT score that was developed by the Stanford the Stanford Integrated Psychosocial Assessment for Transplant. This is a very comprehensive tool, uses multiple demographic, clinical, and variables. It was originally designed not specifically for alcohol relapse, but has been shown to predict relapse after the liver transplantation with the robust AUC. We also recently, from a study from Memphis that we published, we also showed a score specifically looking into who would have a harmful relapse after liver transplantations. We zeroed on 4 variables, that is age at transplantations, alcohol abstinence less than 6 months or more than 6 months, number of drinks with less than 10 and more than 10, and criminal history. And we came out with a score called HALT score. Also, we found with the 100 times we have validated internally, and we found has a very robust ROC, as you can see, almost 0.79, this model predicted. And this needs to be, of course, validated, and we can see whether this can be utilized in different scenarios. Again, these scoring systems can be different in different geographic areas. It may not be applicable in Indian scenario. It may be applicable in other country. It all depends on the specific cultural and geographic scenarios. And again, I see that there's a study from Dr. Sagal's group. Neeraj is also a dear colleague, and they have published this study. They also showed particularly from their center in the living donor liver transplant setting, they have shown that the overall survival was pretty good in alcoholic patients, 88.5% at 3 years. However, what is important, I want to point out that all the heavy drinkers presented with features of graft dysfunction. So I think it's important to find out who will be the relapser in that scenario, and it might be useful to look this different scoring system which can predict these patients' population to reduce their graft dysfunctions. Finally, I will summarize my presentations. First, the use of hepatitis C positive livers in hepatitis C negative recipients is safe with acceptable outcomes. The presence of chronic liver disease was significantly associated with more severe COVID-19 infection and overall mortality. Transplant recipients with COVID-19 appears to have a more severe outcomes. NASH patients with high BMI, particularly NASH patients with high BMI, may have a better outcomes of the liver transplant than non-NASH patients. Frailty assessments may help to identify vulnerable patients, in particularly this group of patients, and those with the BMI more than 35. Role of bariatric surgery before, at, and after liver transplantation is evolving, and I think we need more data on this. The MELD score should be assessed with ACLF score to assess futility of liver transplantation. Normothermic transfusion holds promise for better organ preservation with potentially better outcomes after liver transplantation. And then carefully selected patient with alcoholic hepatitis will have excellent post-transplant outcomes. And with that, I would like to pass it over to Dr. Dharmesh Kapoor.
Thank you, Sanjay. And at the outset, I must concede my bad that I didn't introduce you, even though I introduced the various panelists. So Sanjay Satpathy is the Medical Director for Liver Transplantation at Sandra Atlas Bass Center for Liver Disease and Liver Transplantation, New York. So as you can see in his publication, he is extensively quoted from his own experience, his own published data, and he's published across a number of different subjects. So I think we can set the ball rolling, and I think my first invite would be to Dr. Sudhanshu, who's the overseas guest and joining us as a panelist. Dr. Sudhanshu, what is your perception on accepting hepatitis C positive grafts for recipients who do not have hepatitis C virus? So what is your take on this subject, sir? Could you please unmute yourself? Sir, please unmute yourself.
Thank you, Dr. Sanjay, for excellent presentation. Actually, in our country, we have just started liver transplantation. So I have not much experience regarding this topic. So maybe I'm not the right person to talk about.
Right. Neeraj, would you like to comment on this subject, because this is a very contentious issue, and at times one is pushed to the wall, you know, and even in the living donor scenario, you might have a situation when there is no donor available and someone in the family might be having hepatitis C. So What, of course, that is the just the other end of spectrum, which Dr. Satpathy also mentioned. But what is your take on this subject?
Yeah, so I think there's a lot of data on disease donor transplant now, and like many centers in the US are taking Hep C positive donors in negative recipients with good results. So like Sanjay also said, the prevalence, the DDLT is still a smaller number in our country, and the prevalence of hepatitis C is probably less than 1%. So I'm not sure how big a problem it's going to be in the DDLT setting as of now. And we also don't have a lot of DDLT experience, but I have encountered this problem in living donor transplant a couple of times in the last few months. And recently we had a hepatitis C, there was only one donor who was hepatitis C positive. And so I personally think, and we can have a different opinion, that if the donor is even in living donor, because we are talking of a cure here rather than hepatitis B where there is no cure. So if we have, if the donor has a SVR and his liver is normal and his biopsy shows, no inflammation, then I don't see why, maybe we can even take in living donor. But we have not done it till now. I thought we could, but I was vetoed down in my hospital, and no one from my team agreed actually. So, but I think if we have done a biopsy, if there is SVR, everything is normal, then why not? My colleagues.
Sanjay, in your publication from the UNOS database, you mentioned about the NAT positive and NAT negativity. What about the fibrosis? Because in the deceased donor setting, and you are having an elderly population who also have comorbidities. So are you happy? Because hepatitis C is not the only thing that is going to count towards the DRI. There are so many other things going on with a given donor. So what do you do with your fibrosis assessment to select an organ, even in the deceased donor setting?
Yeah, so all these patients, actually, when they procured, the surgeons do a visual inspection, of course. In the vast majority, that were visual inspection only. But whenever there is a doubt, they will do a biopsy, especially in NAT positive patients. When they certainly, most surgeons would consider doing a protein section biopsy with immediate read, and they do. And we usually would discard an organ with at least a stage 1+ fibrosis. We do discard those organs.
Right, because eyeballing is a very poor way of assessing fibrosis. So
Correct.
it is a good way of assessing the fat, but it's a very poor way of. Neerav, Naimish, would you want to comment on that?
Actually, in my previous unit, we have had an experience of doing a donor who was HCV positive, treated with the DAs, and an SVR was achieved, and then was used as a donor. Now, the recipient did well, the donor is still doing well, but I must say that even though the preoperative biopsy did not show any inflammation, it was a very difficult liver to cut, a very oozy liver to cut. It has to be, one has to take into account that, you may not develop fibrosis in these patients, may not be evident on biopsy, but it also depends how long the patient has had HCV, which is, these patients get detected with HCV RNA being high in positivity, but one doesn't know just how long the HCV has been there. What is the waiting period for, for the inflammation to totally subside? Is 6 months enough, or is 1 year enough? Because in a deceased donor, it's a different, the whole liver is being given. In a living related, you have to cut through that liver. And I think it has to be, one has to be really skeptical about it, about accepting a HCV positive live donor, because one really does not know just how much inflammation will be there, how difficult the liver will be to cut, because there is just no clear-cut norms on it as of now.
So may I ask you that question back to you on that? So in an Indian scenario, like in the living donor transplant scenario, what's your fibrosis level of acceptance in a donor? Any fibrosis is
no, we do not accept.
No fibrosis. Yeah.
No fibrosis.
No fibrosis.
No fibrosis. Same like steatosis also, we won't accept between 20 and 30% steatosis also, we'll think twice before accepting that donor. So in a live related setup, it is the norms
I
are
think in the interest of time, Nimish, I'll take that opportunity away from
No
you.
problem.
But I like,
No problem.
Yeah, I like you to comment on another very important topic which Sanjay raised, which is the obesity paradox. So, what is your take on that? So, Sanjay mentioned in his talk that obese patients with NASH, they tend to do better after liver transplant.
So I was very intrigued with his talk. I mean, this is completely contrary to what we would have expected to see. So those patients with a higher BMI with NASH, from your presentation, they tend to do much better, and that's what we have seen. But what we normally feel is that those patients who have a higher BMI with NASH actually should be performing much worse as compared to those who are lean. And in our country now, we have started seeing lean NASH, which is much more as compared to obese NASH, which we are getting now. This is something which is very interesting.
So do you want to comment on that? Do you want to comment on the, we discussed this issue recently when we published the nutrition guidelines. So I think there is some truth to this observation. Would you like to comment on that? Suni, are you on?
Hello?
Yeah, please go
on. Audible?
Yeah, you are.
Yes, sir. Yes, sir. So we've just done a small analysis on sarcopenic obesity, and the prevalence was around 30% in all our patients. And we saw that patients who have alcohol and NASH, both components of metabolic syndrome, have high prevalence of sarcopenic obesity, and the muscle mass is quite less as compared to the other group. And the outcome of these patients, when we look at the pre-transplant outcome, the hospitalization rate as well as their mortality is much higher as compared to what it is with other groups without obesity. So I'm not very sure whether obesity is a confounding agent here, or it's, the implication of obesity is that it is causing poor outcomes in pre-transplant patients. But as Dr. Sanjay has shown that the outcome might be better in patients who have a higher BMI. So I would be a little skeptical about this study.
Sanjay, what is your thinking on this subject? So, of course, I myself believe strongly that there is this obesity paradox. It's not just in transplant, but in some other surgical specialties also. So people who have this kind of a quote unquote, even a poor reserve, but this is a reserve of energy, and they tend to tide over these crisis situations much better. But what is your take on that? And how do you then counter the same kind of results in the non-NASH group, wherein the obese people are not doing so well?
Right. The pathogenesis, I believe this is related to that, as I talked in also in my presentation. I think it's related to a couple of factors. One, I think, is the pathogenesis itself that is being reversed. That is the insulin resistance with improved glucose utilizations in patients, particularly with NASH, which is causing the NASH disease, and the peripheral and the glucose disposal that is improving after the transplantations, in particularly NASH patients. And the second, I believe, the selection in these patients, because there may be more comorbidities in these groups. This is a retrospective study. This is not a prospective one, and we have to take this with a pinch of salt as well, because NASH patient probably has multiple comorbidities. So whatever patients are being selected out for transplant, I believe they're the best one, even if they have the obesity. And the other groups probably doesn't have that much of comorbidities other than hepatitis C and obesity, or let's say hepatitis B with obesity. And those comorbidities are being, those comorbidities also playing a role in their outcome. So we kind of did a separate subset analysis, earlier cohort and the later cohort as well. But again, there was just the difference in the survival in the non-NASH groups across the different class of obesity was not as apparent on the later cohort as compared to the earlier. I believe this is maybe related to the DAF being introduced in those group of patients in the non-NASH groups. But again, this is, and the other third point that I would like to bring up, maybe sarcopenia, which is under-recognized in this NASH patients groups. So far, they were not being routinely used to select out these patients. So sarcopenic patients, particularly those who are very small or malnourished and they have NASH, likely are doing worse. And that's why they have the worst outcome in those group of patients.
So there is a selection bias. Is that what we are trying to?
So I think Sanjay, the crux lies in the fact that the non-NASH obese people, mostly in the US and from the era that you've taken the database from is the hepatitis C etiology patients. And then this is probably also from the times when we did not have effective anti-HCV treatment. So maybe if you were to look at these data in a prospective manner, you might see the same kind of obesity paradox in this group too. But there exists an obesity paradox, and therefore I'm a strong believer in the fact that all fat is not bad. So Ashish, I see you also in one of the panels, though it was not described or it was not mentioned to us. So let's pick your brains on frailty, and in your program, how do you assess frailty for your transplant recipients? And would you ever reject someone just based on the basis of frailty?
Frailty, actually, in our part of where the liver donors are so scarce, and we hardly get, so we should not be so restrictive in choosing our donors, and we would not like to reject our donors just based on the frailty index. But I would also like to point out that as we are expanding our donors pool, then and we get more and more patients and more and more donors, then we get a chance to do select. But I would like Dr. Namish's opinion, because in Gangaram Hospital, how is he choosing their donors?
So again, sorry, I just wanted to clarify. Frail test, we are looking at the recipients, I suppose. Yes. So for donors, we would obviously want a fit donor, and if the recipient is fairly frail, where we expect that he's not able to get up from the chair, and then he's not able to move around, these patients are unlikely to do well post-op, and these are the patients who have a very stormy post-op and difficulty coming out, and these patients ideally should not be subjected to transplantation. Regarding Dr. Ashish's question, yes, for the donor, we would actually want a fit and a healthy, suitable donor, no doubt about that.
Right. So quickly switching gears, and I think we are shortly running out of time. We are running out of time. Neeraj, your take on transplantation for ALK-HEP, not alcohol-related liver disease. So what are your views on that?
So yeah, I think, you know, we as a center do transplants for alcoholic hepatitis, but I think it's very difficult to select the right patient. And, you know, the patient who has been given a trial of steroids and has failed and needs a transplant and doesn't have any contraindications, you know, in the form of sepsis or renal dysfunction, you know, it's very difficult to find the right patient. So it's easy to say that we do transplants for alcoholic hepatitis, but you rarely find a patient who fits the bill, you know, who needs the transplant and is fit also. So I think it's a very small number, but yes, I am personally in favor of doing it. I mean, I would not let a alcoholic hepatitis patient die just because he doesn't meet the criteria for, you know, 6 months or 3 months or whatever. So, but I think it's a very small number of patients who actually can undergo transplant.
Sanjay, regarding your scoring system for recidivism, you know, these are recent scores, and probably these are post hoc analysis from a number of databases. But equally important, and probably one of the finest studies that has ever been done on recidivism, are the trajectories of alcohol consumption. So I think maybe that is something which is worthwhile for those who are in transplantation to know. So you might have a high score right at the outset, but you know, people who start or who slip early on in the post-operative course after transplant, they do not do as badly as those who start to take alcohol some years into transplant, albeit in moderate amount. So what I'm trying to say is that an early guy who's having a slip or who even takes hazardous alcohol is not as bad as someone who starts to take alcohol some years into transplant, and even if he's having moderate drinking. So I think these trajectories after transplant are very, very important. The database that you showed from Neeraj's group is actually a mixed bag. So they have got patients with alcohol-related liver disease, and mostly about 10 to 30% of them will have some intake of alcohol in the post-operative period, though not always taking it in hazardous amounts. So for the surgeons, and this will probably be the last question, what are your views on normothermic machine perfusion? Do you think it's something that we should be thinking about? The Western world uses only deceased donor transplants, and if I'm not mistaken, 1/3 of their organ pool is now DCD. And we hardly do take any DCDs even in the southern part of this country, where we do at least 20% of our transplant activity as deceased donors. So what are your views? Nemish first.
So yes, I agree completely. This machine had actually come to India for a shorter period, and I think it didn't work out as well as the points which Dr. Dharmesh has already pointed out. We do far less number in terms of cadaver organs, and we don't do DCDs as of now. Most of the transplants are actually living donors. So this machine is ideally suitable only where the graft has to be transported at a longer distance, and you want to the time to buy the time. So in our country, at least, the graft is actually utilized in wherever regional centers or even in the same city. It is rarely that the city or the state is crossed, or you transfer across the nation.
Neera, what about the marginal donors? So, these livers are very few and far between that you get in north of India. So supposing you were to get someone who's got say 50-60% fat, and you are desperately looking for a cadaver organ, and one comes your way. So would you be happy to subject it to machine?
For us, any cadaveric graft, because there's just so few and there's so many patients who do not have live donors waiting for it. So each graft needs to be given its best, to try and save that graft. But machine perfusion is a good thing. There is no doubt. I think normothermic perfusion definitely has decreased the discard rate of the grafts. Hope the hypothermic perfusion also has shown even better results with the bile duct injuries. But the bottom line is the cost and the practicality of it. In India, if you have to, while the machine was here, if you have to ship that machine, the Organox machine from from South India to North, the total cost was about 7 lakh rupees, about $10,000, and it's just not practical in Indian population to for the population to afford that over and above the cost of a transplant. And also, I think for the company, they will go bankrupt. Like the number of transplants being done, cadaveric transplants being done in the country as of now are just so few to really justify the use of normothermic or hypothermic perfusion. But that said, these machines have shown excellent results, particularly for disease donation after cardiac death. In Indian setup also, there are many DBD donors who are in a bad cardiac status, and they're in a bad shape before being eligible for declaration and for transplant. So definitely machine perfusion will help, but the numbers just have to go up before this can be done practically in our country at least.
So Sanjay, I think this is all very interesting and really, rakes up your gray matter for research, especially with respect to the IR injury. But the only thing is the trial that you mentioned, which got published in Nature, there was no difference in outcome. And I think if you were to run the statistics by taking away the DCD from the two groups, you might not see any significance. So, this definition of EAD, which is used in the deceased donor transplant setting, I am really a baiter for that. So this is at best a very poor definition. The level to which the enzymes rise, or the level to what your INR is on day 7. So you'll have many patients who will have characteristics like this, but they make very rapid recovery once you've sorted the first few days out. So maybe in the first few days you might be able to get away with not having such a stormy course, but I don't think in the overall scheme of things this is hugely beneficial. And I think your point on the ACLF and MELD, that is well taken, and all of us agree to that MELD does not completely define the ACLF syndrome, and it's the organ failure. And even in the non-transplant setting, critically ill cirrhotic patients who are on ventilator, they are probably the ones who do the worst. So I'm not talking of the transplant setting, but even in a critically ill ICU-bound cirrhotic patient, those who are on the ventilator, they are the ones who've got the worst outcome for their survival. So I think I thank everyone for a very active participation, and I again thank Sanjay for sharing his experience with us, and I hand over the mic back to Professor Anil Arora.
Thank you, Dharmesh, for excellent moderation of the session. And I'm thankful to Dr. Sanjay Satpathy. I still recall the days, early days of COVID, when Dharmesh, we didn't have anything to do but sit at home. So we would present multiple seminars and webinars on COVID. Sanjay will present the management, I'll present the pathogenesis. And I'm happy to see most of his research, publication, and data collection has seen the light of the day. So with that, I am thankful to all the panel members, the moderator and the speaker of the session. To sum up to give you the summary of the day before Dr. Ashish gives a vote of thanks, let me just give you a recap of what we have learned today since the evening. The first presentation was by Professor Zubair Junaisi, who did talk of his own wide experience of collection of the epidemiological data throughout the world, simply and very categorically stating that it has an economic, medical, social, and the medical impact on the health of the country. In addition, he talked of multiple need of the R was the definition of a non-invasive test of a patient who needs the treatment. That still remains undefined. And finally, he did touch upon newer drugs which are going to see the light of the day. But I think if we have to summarize the whole topic in one sentence, I'll go by what Dr. Sareen mentioned in his talk, that a 600 calorie diet for a period of 3 months gives you as much of a relief in fibrosis as would give you a drug which requires a therapeutic trial to show its efficacy over the next 5 years. The second talk of the day was by Professor Robert Gish, who talked to us about hepatocellular carcinoma. The salient presentation and his main points of discussion were the three major takeaway messages were Gallard's, Lyrad's recent concepts of the biopsy, ultimately leading to so-called personalized therapy. It did talk of the newer concepts of early diagnosis, the newer definition of Lyrad. I'd like to know from Dharmesh, why is it that most of our radiologists and especially the hepatologists are still not using Lyrads as for the definition of and the radiological assessment of hepatocellular carcinoma, and the fact that we have newer concepts of the biopsy coming into being for diagnosis of HCC, which was something which was based on radiology till date. And finally, we are for the first time seeing the smaller molecules, the combination of bevacizumab and atezolizumab, which gives you a much better survival in patients who have advanced disease. Professor Sareen in his third talk did try to rename the already incomplete name of a disease called non-alcoholic fatty liver disease, which is a heterogeneous, complex disease which includes anything which is everything but alcohol. That is non-alcoholic liver disease. From there to shift over to something like metabolic associated liver disease or MAFLD, I think it amounts to the same thing, because you do not know the difference between a chicken and egg theory, whether the metabolic syndrome causes fatty liver or fatty liver disease per se causes metabolic syndrome. So that conundrum still remains undiagnosed. But there are, because of the complexity of the problem, I still think we are still looking for a more homogeneous definition of a disease, which still needs to be defined very well. In the fourth talk by Professor Ashwini Singhal, we had very good concepts of recent advances. He clearly mentioned that the drug of choice for treatment of hepatitis B is tenofovir. He has shown the efficacy of data both in pregnant women and also emphasized on the safety of this medication in the breastfeeding and pregnant female. Next thing he touched about was the recent use of immune check inhibitors, which have been popularly used by the rheumatologists and clinical immunologists, and then are stepping into our own arena of hepatology. And as hepatologists, we have to be aware of the recent complication associated with immune checkpoint inhibitors in terms of autoimmune hepatitis, which is occurring in about 10% of these patients, and we should know how to diagnose and manage it. Dr. Ashwini Singhal also told us about the newer advances in management of autoimmune hepatitis, in which he did stress that if you have a patient who is not tolerating the first line drugs or person who is not responding to it, the tacrolimus is the drug of choice before you end up thinking of drugs which far more immunosuppression than this. Finally, we had a talk by Dr. Sanjay Satpathy, who had been doing an excellent work right from the day of start of COVID-19 infection. He has been into the thin and thick of COVID-19 and the liver, and we have been listening to his mesmerizing talk since then. I think the four major takeaways from his lectures are that at least in that particular area in Western world, there is some utility of using hepatitis C related donor. But as Dr. Dharmesh, Neeraj and others have pointed out, with our own Indian positivity in blood bank of only 0.9%, of which only 60% may be HCV RNA positivity. And when most of the liver transplantation in Indian scenario tend to happen as an LDLT program, I think it may have limited utility, at least in North India, where LDLT is the major program. For the first time, we have been hearing of the advantage of being obese. I think that is a scientific data, but I'll agree with Dharmesh that it is our own observation that at some time, if you have an epidemic or a dengue virus infection or pneumonia or malaria, you would see obese people doing well in ICU setting. That has been an observation by most of the astute clinicians. And I'm happy that Dr. Sanjay Pathi has put some life into that, at least in the transplantation era. There is explanation that after liver transplantation, you are getting a new liver which will be able to utilize the glucose better, but still we are not sure whether the peripheral hepatic insulin resistance will go away with new liver. That is something which needs to be seen over a period of time. But in any case, obesity paradox is a phenomena which has been documented earlier by clinical assessment of the astute clinician, but possibly seeing the scientific data now. Liver frailty index has been a useful measure of knowing the utility of LDL of the DDLT program in the Western world. But if you go by the practical situation in India, where transplantation is either do or a die phenomena, that means either you end up losing the patient or saving the patient. I think most of us as hepatologists or transplant surgeon, at least in the LDLT program, will hardly ever reject a person who otherwise fits in with the criteria. But if we are doing something wrong, I think with passage of time, we should learn. And finally, he did talk of newer concepts of trying to find out who is going to relapse after liver transplantation in alcoholic liver disease. I think in our own Indian scenario, we have documented data of about 20% recidivism, of which not all of them may be damaging their own liver after resumption of alcohol intake. With that, Dr. Dharmesh has a comment. Dharmesh, you can
So I think, sir, you have summed it all. And in recent times, we have been using LIRADS and the LIRAD scoring system from 1 to 5. That just tells you how good your imaging is. So 4 and 5 is something that you would want to treat as HCC, and anything lower than that is something which is suspect or indeterminate. So I think more and more radiology centers, when they're reporting this, and earlier we were using only things like arterial enhancement and portal venous washout. So now it's a metric that sums it all. So what is happening to the capsule, what is the pattern of enhancement, what is the pattern of washout, and then you also have an extension in.
I think everybody should be using it as a routine.
Yeah, yes, sir. Yeah. And then even when in indeterminate lesions, you use the LIRADS M when you are not sure whether you're dealing with an HCC or a metastatic disease or an intrahepatic cholangio. But I think you've summed it quite nicely. But all the talks were great. It was a great session of hepatology this evening.
And with that, may I request Dr. Ashish Kumar, who is our senior consultant, to please give a vote of thanks to all the speakers, audience, participants, moderators.
So on behalf of the organizing committee of clinics in Hepato-Biliary disease 2020, which has been organized by the Institute of Liver, Gastroenterology and Pancreatobiliary Sciences of Sir Ganga Ram Hospital, and in association with Delhi Liver Foundation, I would like to thank all the speakers for delivering very lucid lectures, covering all the recent advances and summarizing all the contents in very short allotted time. 20 minutes is really short time to cover broad areas, but they did a wonderful job. And I would also like to thank all the panelists and moderators for making each session very interactive, information and lively. My special thanks also goes to the international speakers and international expert panel members, because who participated in spite of being in the odd time in their part of the world. And since no conference is considered successful without the participation of delegates, I'm very happy to inform that we had at least 250 participants and most of them remained logged in for a lot of lectures. And I would like to thank them for their active participation throughout the conference. I would also like to thank the Micro Labs as our academic partner and for their logistic support. And last but not least, I would like to thank the event partner, which is MyProvidi, and especially Mr. Pranav Viswas for providing the excellent platform for this meeting with flawless management. I would like to invite all of you for tomorrow's meeting, which again starts at 6 p.m. And the theme of tomorrow's meeting is pancreatic-biliary disease, and we have excellent speakers lined up for that. With this, I would like to hand over to Dr. Anil Arora to conclude the session.
Thank you very much. One small correction, Ashish, the total number of the people who had logged in was 1,700 because there were 2 screens.
Okay.
Total number was 1,700.